talk is going to be about rheumatoid arthritis, combination puzzles. Okay, and so I don't have any disclosures to mention here. The agenda of my talk is going to include these aspects regarding the evolution of rheumatoid arthritis treatment, and we will shed some lights about our old friend, the methotrexate therapy, the importance of this drug in the anti-drug antibody, during methotrexate therapy, and some updates about the combination therapies and the treatment sequence in rheumatoid arthritis. So I think we have seen great advances over the years in the treatment of rheumatoid arthritis. And you can see this timeline depicting the various treatment options in the treatment of rheumatoid arthritis. Actually, it started in 1950s when we have the introduction of corticosteroids in the treatment of rheumatoid arthritis. And then we've seen the assurance of new eras of treatments, starting from the methotrexate in 1988. And then from the 2000 era, we had a lot of medications, the biologics targeting cytokines, making a lot of innovation in the treatment of rheumatoid arthritis. Now, these treatments were kind of targeted, looking for specific, molecules. But we know that rheumatoid arthritis is a complex disease. And you might choose one treatment like anti-TNF, but it doesn't work in this type of patient. It works in another patients. So although it is really very interesting to see these kind of target therapies, but the problem is that we don't know what treatment is going to be suitable for which patient, and unfortunately, until now, we do not have a biomarker that tells us which drug to use. So we have now a long list of medications in the treatment of rheumatoid arthritis. One of the things that might really interest us is that we have drugs that have multiple mechanisms of actions, like methotrexate, and we've seen this also in the anti-JAK antibodies. These drugs might work on different sites and might help really to give us some sort of responses in those patients, because we know there are different pathways involved in the pathogenesis of rheumatoid arthritis. So looking into the mechanism of action of methotrexate, although we do not know the exact mechanisms, but there are certain speculations and some literature aspects related to the mechanisms of methotrexate in rheumatoid arthritis. We know that it has some interesting actions on the promotion of the extracellular adenosine accumulations, and this molecule is important in the modulation of immunity. The inhibition of key enzymes like the dihydroreductase that is involved in the purine and pyrimidine pi synthesis is an important mechanism for this drug in modulating the T and the B cell responses in the immunity. Inhibition of JAK-STAT pathway has been found to be one of the aspects of methotrexate therapy. These kind of mechanisms will result eventually in decreased synovial inflammation and reduced joint damage, as well as improved clinical outcomes. So again, this cartoon here that I'm going to show you is going to give you the mechanism, the various mechanisms for methotrexate, as we have already talked about them. And it's a very, interesting to look back into the different mechanisms related to methotrexate, where there's not a lot of, literature talking about it. Now, if you look into the how does methotrexate influence rheumatoid arthritis treatment, we know that almost over 80% of the patients with newly diagnosed rheumatoid arthritis are initiated on low-dose methotrexate as the first, DMARD, and either as monotherapy or as part of combination therapies. We know that long-term persistence rates are high. And a recent cohort study found that 81% of patients remained on methotrexate at 5 years and 51% at 9 years. This is something really great, because we know sometimes that not a lot of patients like to take this drug, knowing the fact that it can be chemotherapy medication. But we found that, at least from some recent studies talking about its persistence over the years. The methotrexate remains the anchor drug in rheumatoid arthritis, as you know. And the majority of the patients with rheumatoid arthritis are treated with methotrexate at some point during their course of disease. So one of the important things that we found in the literature is the importance of this drug, methotrexate, in decreasing the anti-drug antibodies, making them persist over the years. So the antibody responses during methotrexate treatment is an important aspect. And if you look into this study here, looking into those patients who are using it with the biologics, you will notice that the anti-drug antibodies represented on the vertical line and the horizontal line represent the time. You will notice that the patient who did not take methotrexate, they are taking mainly the biologics, there is development of a lot of anti-drug antibodies compared to those patients who are taking methotrexate, represented in the blue line and the dark and the blue lines. There is less development of anti-drug antibodies, meaning that using methotrexate plus a biologics will help actually reduce the anti-drug antibodies and probably the loss of efficacy of these medications. Again, not only it helps in reducing the anti-drug antibodies, but that way you will be able to increase the trough levels, the concentration of the drug in the systems. So you will notice that, for example, if you are using adalimumab plus smaller doses of methotrexate or using, for example, anti-drug, using the adalimumab in these situations plus higher doses of methotrexate, you will notice that the concentrations increases, the trough levels increases when you use higher doses of methotrexate, at least from 10 milligrams and above. So this is something also good for the survivability of these biologic molecules. So looking into the update in the treatment of rheumatoid arthritis and specifically focus on the combinations, you will notice from the recent EULAR update 2022 that once you have the diagnosis of rheumatoid arthritis, you confirm this diagnosis, and if there's no contraindication to methotrexate, that's the drug that you're going to start with. So you start with methotrexate, and you might give some sort of a bridging corticosteroid therapy in the EULAR guidelines. And then if the patient, you assess him over 3 and 6 months, if the patient showed improvement on the drug and achieved the target at 6 months, then probably you will continue this drug, and you might even, if the patient is in sustained remission, you might even lower the doses afterwards. However, if the patient had inadequate response to methotrexate, then you will need to escalate the therapy, and in these situations, you need to add a biologic DMARDs only if the patient is having bad prognostic features. And you can see that the bad prognostic features outlined actually there, including high levels of rheumatoid factor and anti-CCB, high disease activity, early joint damage, or failure of at least 2 or more conventional synthetic DMARDs. So here you will need to add a biologics or a JAK inhibitor only if after risk assessment for the JAK inhibitors, knowing the side effects associated with it. Now, what is interesting about EULAR that they have looked into those patients who are not having poor prognostic factors. So in this patient, you might not need to start a biologics in this situation. You might go for combining methotrexate with a conventional synthetic DMARDs like leflunomide or sulfasalazine, or maybe triple therapy, leflunomide, sulfasalazine, and hydroxychloroquine. And this is ways that you need. So you see, still, the methotrexate is an anchor drug for the treatment of rheumatoid arthritis. You will only stop it if the patient cannot tolerate it. Otherwise, you need to continue on the molecules. Now, what's more interesting is the ACR 2021 guidelines. They have really focused heavily on the use of methotrexate. And specifically, when you use it as oral and you may need to shift it as a subcutaneous methotrexate, you might even need to split the dose in order to get the maximum efficacy of the drug. So in here, you will notice that newly diagnosed RA patients with moderate to high disease activity should take methotrexate alone rather than other conventional synthetic DMARDs. And the aim is to have a dose of 50 milligrams or higher in those patients. Insufficient response to this molecule, if not at a target, you need actually to to either use subcutaneous methotrexate or you split the dose of the methotrexate. And once the patient is labeled as inadequate responder, in that situations, you need to escalate therapy to a biologic. Here, they do not recommend using, combination of methotrexate with conventional synthetic DMARDs. And this is the way it was outlined in the ACR 2021. The reasons I think they depended on some of these studies. For example, if you look into the TEMPO trial, I think it's known to everybody. It was published in 2006. This treatment was comparing the methotrexate versus etanercept monotherapy versus the combination of methotrexate and etanercept therapy. And if you look into the result of this trial, the yellow and green lines represent methotrexate and etanercept as monotherapy, and the red line represent the combination. The vertical axis represent the mean DAS scores, indicating the disease activity, and the horizontal line represents the time. So what you see here clearly that the combinations of methotrexate and etanercept is showing superior results, superior efficacy in reducing the disease activity in comparison to the monotherapy. What is more interesting is that the methotrexate is as good as the etanercept when it is used as monotherapy. There is no significant benefit if you use etanercept as monotherapy. So always you need to use it as a combination therapy to have the maximum efficacy. The same thing if you're looking into the remissions in DAS. In the first year, represented in orange, and second year in blue. So you will notice that the methotrexate and etanercept, they are having comparable results if they are used as monotherapy. But when you combine methotrexate plus the etanercept, you will double the responses. So this is probably the reason why the ACR requested combinations with, biologics. Now, what is the advantage that you will notice is that if you use etanercept monotherapy, you might have advantages in terms of radiologic damage. You can see that the methotrexate is having some benefits in terms of radiologic damage more than methotrexate, because methotrexate is represented in this dotted line, and you can see that there's more damage progressions in comparison to methotrexate, but the combination is doing better than both. Now, what about the combinations of the biologics with either methotrexate or other conventional synthetic DMARDs? From this study, we see, for example, on the left aspect of this slide, you will notice that the benefit is towards methotrexate combination with the biologics more than if you combine it with conventional synthetic DMARDs. So this is clearly showing that there is superiority of the benefits if you use methotrexate instead of other conventional synthetic DMARDs. If you compare, for example, the methotrexate versus leflunomide, again, you will see that the risk ratio of good and moderate ULR responses comparing methotrexate plus TNFi versus leflunomide plus TNFi, you will notice that the result is in favor of methotrexate. So again, it's still a good, actually, drug to use in this situations. This is a recent network meta-analysis for comparison between DMARDs versus combination therapy, and this is a Japanese, study. It was reported in at the beginning of 2025. What you need to know is that the combination of the biologics plus, DMARDs, any of them, including methotrexate, it is definitely superior than if you use the biologics alone. What they found, actually, because the good thing about the network meta-analysis is that they can compare indirectly the different combinations without doing a trial. They looked into the different trials in rheumatoid arthritis. So in this situation, they found that, for example, the combinations of methotrexate plus etanercept was the best in terms of the efficacy and the safety. You might have some good efficacy, for example, the anti-TNF, the methotrexate plus JAK inhibitors, but it is more associated with toxicity. So this is one of the things that has been highlighted in this network meta-analysis. What about the triple therapy versus biologic and targeted synthetic DMARDs. I think you already know that the triple therapy, for example, methotrexate, sulfasalazine, hydroxychloroquine, were compared to the combination between methotrexate and a biologic. And the results showed that in terms of the clinical manifestation, the symptomatology, both drugs, they do well. Both combinations, they do well. Maybe the only advantage is in favor of the methotrexate plus the combination with biologics in terms of radiological damage. And here in this study, for example, in the Corona registry, this study, it shows that the TNF plus methotrexate, they do better than the triple therapy in the combinations. This is probably why the ACR were shifted to go for a biologic plus methotrexate instead of going for conventional synthetic DMARDs combinations. Probably also the toxicity is even more in that situation. What about the biological survival when you combine with or without methotrexate? So definitely if you combine biologics with methotrexate, then you will end up having more survivability for the biologics in the situations. And this study, for example, is showing you that in the light, gray line representing the combination of methotrexate and a biologic, it has more survival capability than if you use the biologics alone. And this is a good message for you that definitely always try to use methotrexate if you are using a biologic. Because those patients who did not take methotrexate, maybe a quarter they dropped the biologics in a few months. Now this is a larger scale real-world data depicting the complexity of the DMARDs treatment sequence in rheumatoid arthritis. And this is a UK actually database looking into 16.6 million of patients from the UK patients in the primary care setting. And it is representative of the general population focused on the RA patients on methotrexate. So if you look into this study, looking into the usage of methotrexate in the general populations, this is the patients who have rheumatoid arthritis. It was including about 25,000 patients. You can see the age of the patients. They are towards the elderly population. You can see the acute phase reactant. They are all elevated. The rheumatoid factor and the CCB represents about probably 60% of the patients. And you can see actually the use of the treatment modalities in rheumatoid arthritis in the patients from UK. So in these situations, you will notice that methotrexate is prescribed in almost 93% of the patients, almost 94% of the patients, oral methotrexate. So how many of them they use subcutaneous methotrexate? It's only about 4%. Subcutaneous, it's 94 and 6% they are using the subcutaneous methotrexate. So the average dose was around 15 milligrams per week for the oral and 20 milligrams for the subcutaneous. 30% of the patients changed the dose in the first 4 months. So you can see among those 94% who use oral, 22% of them, they have shifted to subcutaneous methotrexate in the first 4 months. This is really important in order to achieve better benefits when using subcutaneous methotrexate, having more efficacy, especially with doses above 15 milligrams. So looking into the therapeutic journey over time, you would notice that probably 2/3 of the patients who used initial methotrexate, they were shifted to methotrexate plus biologics in the situations, the TNFI, the most likely to be prescribed after inadequate response to methotrexate. Almost half of them represent methotrexate plus the biologic TNF, but some of the patients, they could not tolerate the methotrexate, they had to stop it, so they went on only the anti-TNF alone. And we know this probably not the best strategy, but sometimes you are forced because the patient is not able to tolerate methotrexate. Some of the other patients, they have used methotrexate plus non-TNFI, and some of them, they use the non-TNFI medications alone, as you can see here. And the story continues. This just tells you how many of the patients will be on oral methotrexate plus a biologics. You'd notice that 58% of the patients will be on these combinations, oral plus the anti-TNF. However, 35%, about 1/3 of the patient, they will use subcutaneous methotrexate plus the biologics. And probably small portions will use the methotrexate plus JAK inhibitors, or in oral or subcutaneous in similar proportions. So again, here just tells you that some of the patients, almost two-thirds, they will use the oral, one-third they will use the subcutaneous methotrexate. So with that, let's come to the conclusions of my talk. Methotrexate is the cornerstone of combination therapies. Methotrexate is recommended in association with biologics and anti-TNF in particular because they improve the effectiveness and enhance actually the drug maintenance, as we have seen. Methotrexate is important for reducing immunogenicity and for improving actually biological survival. Methotrexate plus biologics is superior than combination with conventional synthetic DMARDs in preventing radiological structural damage progression. And if methotrexate is intolerable, probably tocilizumab or JAK inhibitors can be used as monotherapy, as they were superior to methotrexate alone when compared in the randomized controlled trials. So with this, I end my talk, and thanks a lot for listening.
Thank you, Dr. Ziad. And I think we'll see more puzzles in the near future, especially if you combine the sub-Q methotrexate with the biologics, which is rarely used now. Good morning, everybody, and thank you for coming in this morning. I have my disclosure that here that my love to Al-Qasim people and Al-Qasim land. يعني حبي لأرض القصيم، أرض النخيل، يعني لا يوصف، يعني وأهلها أهل الكرم أكرمونا صراحة. I would like also to thank يعني fifth annual Qasim Conference organizing committee for give me the pleasure, the honor to participate in this conference. And now we'll go to the second session. I want to introduce Dr. Mansour Al-Sumaili, who is a consultant rheumatologist, assistant professor, King Khalid University, and he's rheumatology program director in Armed Forces Hospital. His topic is not common to attend, which is rheumatoid arthritis and fertility, treat-to-target approach. So this is the first time I attend such topic, so I think it will be very interesting. Dr. Mansour, stage is yours.
السلام عليكم ورحمة الله. بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله. Thank you, Mr. Chairman. It gives me a great pleasure and honor to be with you this morning, talking about the treat-to-target strategy and its role in improving fertility in patients with rheumatoid arthritis. Before that, I would like to thank Dr. Sultan, Dr. Al-Faraj, and all the organizing scientific committee for this fabulous meeting. I have nothing to disclose. These are my agenda. I'm going to talk about rheumatoid and subfertility, the impact of disease activity on fertility, the medication effect on fertility, and the role of treat-to-target strategy in improving fertility of patients with rheumatoid arthritis. We have various definitions for infertility, but the most universally accepted one is the inability to conceive within a one-year frame. The female factors include tubal damage, endometriosis, uterine abnormalities, and of course the age. And male factors include the disorders in spermatogenesis, oligospermia, azoospermia, and ejaculation dysfunction. But almost 30% of patients, the subfertile couples, they have unknown etiology and commonly referred as unexplained infertility. And many chronic diseases have been classically linked to the risk of infertility, including rheumatoid arthritis. Before we will go to the female RA patient with subfertility, just quick overview over the male subfertility, which has been less extensively studied than the female infertility. But what we know is that male RA patients, they have lower level of testosterone compared to the normal individuals. And the sulfasalazine, it will decrease both the number and the motility of sperm in males. And usually this decline will improve within 2 months after stopping the sulfasalazine. There were some old data suggesting to stop methotrexate in male RA patients before they will plan to have children with their spouses, but this worry has been eliminated in more recent studies. Methotrexate, it will not compromise the subfertility, although there are a few data suggesting that, but there is till now no good evidence to indicate that methotrexate can compromise fertility in male, but you know it is a teratogenic drug and should be stopped 3 months ahead before they will plan the conception. But other medications like NSAID and steroid may cause impaired male fertility. Again, TNF also, it will not compromise fertility in both males and females. When we are talking about female RA patient and infertility, it has been reported that female RA patient, they have smaller family sizes and they have prolonged time to pregnancy, or what they call TTP, time to pregnancy, and they are using the assisted reproductive techniques more frequent than the normal people. And almost 40% of patients with RA experience infertility compared to almost 10% in the general population. And in most of the cases with infertility in female RA patients with infertility, you can't identify the etiology. And commonly they have what we call unexplained subfertility. Furthermore, patients with rheumatoid, they are also more liable to have the pregnancy morbidities, including preterm labor, miscarriages, and cesarean. I will come to this later. Decades of studies have linked the risk of infertility with rheumatoid arthritis. But let us just categorize the potential causes of infertility in patients with rheumatoid arthritis. Is it related to the disease activity or the medications that we are using in rheumatoid arthritis, or due to hormonal disruption or physical and or psychological impaction of rheumatoid arthritis on the reproductive system of female RA patients? Basically, all of these factors have a role in the infertility in patients with rheumatoid arthritis. Pain and fatigue, which would result into some decrease in the sexual function, increase in the pro-inflammatory cytokines, which will inhibit the ovulation, as well as the medications that we are using in treating patients with rheumatoid arthritis, namely NSAIDs and high doses of steroid. So chronic inflammation with increase in the inflammatory cytokines, hormonal dysregulation with alteration in the hypothalamic pituitary ovarian axis, it may ultimately lead to reduce in the ovarian reserve. Other coexisting factors that compromise fertility in rheumatoid patients include polycystic ovarian syndrome, endometriosis, and premature ovarian insufficiency, which are reported more frequently in RA patients compared to the normal population. Interestingly, large proportion of patients with rheumatoid, large proportion of patients with unexplained infertility without rheumatoid arthritis, they have high inflammatory cytokines like interleukin-6 and JAK. And this will reflect or it may suggest underlying immune-mediated disease induced with unexplained infertility. And even some of the studies correlating the level of these cytokines with the risk of infertility. So they could have those with unexplained infertility without underlying autoimmune disease. They may have underlying immune-mediated disease. There is a strong association between endometriosis and autoimmune diseases like SLE, rheumatoid arthritis, IBD, and other autoimmune disease. And the other way around, those with endometriosis, they are at higher risk to have rheumatoid arthritis. And this is the largest population-based study done in Asia, in which they have enrolled more than 30,000 patients. Almost half of them, they have endometriosis. They found that those with endometriosis, they are at higher risk to have rheumatoid arthritis compared to those without endometriosis. But again, these data should be interpreted carefully because, you know, endometriosis and rheumatoid are more in those who are above age of 40, so you can't generalize this rule for all the age groups. Psychological and the psychosocial impact of rheumatoid on fertility, and you know that almost 15% of patients with rheumatoid, they have major depressive disorder, or maybe larger proportion, they have anxiety disorder. And these psychosocial disorders may compromise the fertility in patients with rheumatoid arthritis. So rheumatoid is a stressor that can compromise fertility as well as the pregnancy outcome. Rheumatoid patients, they have alteration and disruption in the hypothalamic pituitary ovarian axis, and commonly they have fluctuation in their estrogen and progesterone level, which will result into irregular menses. Furthermore, rheumatoid patients, they have higher level of prolactin compared to the normal individual, and you know that prolactin will inhibit the ovulatory process. There is also a negative correlation between the RF and ACPA titer and the chances of successful conception. The higher the titer of ACPA and rheumatoid, the higher the risk to have infertility. So the studies showed that RF and ACPA positivity were significantly higher in women who didn't conceive compared to pregnant women. ANA in patients without underlying autoimmune disease, almost 25% of patients with endometriosis without underlying autoimmune disease, they have positive ANA. And this again may indicate underlying immune-mediated disease. There is another hormone called serum anti-Mullerian hormone, which is used as the best proxy to measure the ovarian function, and found to be low in patients with rheumatoid arthritis. And again, there is a negative association between the ACPA positivity and the level of this hormone. Some of the studies correlated the decline in this hormone with the risk of fertility, and some are not. This is one of the studies looked for the level of anti-Mullerian hormone in rheumatoid patients, 209 patients. They completed the study, and they have found that those with rheumatoid, usually they have lower level of anti-Mullerian hormone, but in this study, it was not correlated with the prolongation in the time to pregnancy. What about steroid? Steroid, as you know, it will cause some fluctuation in the estrogen and progesterone level, and this is why those who are on steroid, they are commonly having irregular menses, and doses more than 7.5, it has been reported that it will compromise the fertility in RA patient. NSAID can interfere with both the ovulatory process as well as the implantation of fertilized ova into the endometrium. But the NSAID, it will not affect the implantation of the fertilized ova in those who use the IVF treatment. NSAID also can cause a syndrome called luteinized and ruptured follicle syndrome, which is characterized by interruption of the ovulatory process. We have spoken about the methotrexate. The assisted reproductive techniques have been used more frequently in rheumatoid patients compared to the normal population, and usually its results are successful. All the techniques, IVF or the intracytoplasmic sperm injection and other techniques, are successful in RA patients. As we have mentioned, the higher the rheumatoid activity, the more risk to have infertility. But the question, and many studies actually, case series and case reports correlated this risk. And the increase in the DAS28 score is associated with increase in infertility. But the main question remains whether if we optimize treatment for rheumatoid arthritis by applying the treat-to-target strategy, would we improve fertility on those patients or not? I will not talk about the details of treat-to-target strategy, but you know its aim is for remission or low disease activity, and in this particular group of patients use the safe drug in the preconceptional period like the sulfasalazine, hydroxychloroquine, and TNF inhibitors. This is the 2020 ACR of Rheumatology Guideline for Management of Reproductive Health in Rheumatic and Musculoskeletal Diseases. I will just summarize this guideline in this slide. The treat-to-target strategy involves using RA medications that are safe, commonly sulfasalazine, hydroxychloroquine, and TNF inhibitor, and avoid or minimize the use of NSAID and steroid. This is one of the best studies in this field in which they have assessed the fertility in RA patients in a cohort called PARA cohort, in which they have enrolled 369 patients. Almost half of them dropped for various reasons, and almost 178 patients, they completed the studies. This is their demographic data and the disease characteristics. Almost 70% of them, they have RF positive, 60% they have positive ACPA, and the mean DAS28 was around 3.5. You can see here that 96 patients, representing about 55% of the patients, they have normal fertility during all attempts to become pregnant. And almost 45% of the patients, this means 82 patients, they were subfertile during at least one attempt to become pregnant. So RA patients, they have some difficulty and challenges to have successful pregnancy. And when we are saying successful pregnancy, we doesn't mean the number of pregnancies. We mean the number of pregnancies that end with live birth. And you can see here that almost 50% of the patients, in 50% of the patients, you can't identify the etiology of infertility. So they have unexplained subfertility. The other causes of subfertility include anovulation, male factors, endometriosis, and tubal occlusion. And these are the different assisted reproductive techniques that have been used. So the conclusion of PARA study that in unexplained subfertility is more often diagnosed in subfertile female RA patients than in general population, and is related to the preconceptional NSAID use. In this study, they have investigated the role of treat-to-target strategy in improving fertility in rheumatoid patient. They did it on a cohort called pre-CARA cohort, in which they have enrolled 215 patients, and they applied the treat-to-target strategy by using sulfasalazine, hydroxychloroquine, and TNF inhibitor, and they minimized the use of NSAID and steroid. And you can see here that in the pre-CARA cohort in whom they received the treat-to-target strategy, there is the time to pregnancy was shorter than those who didn't receive the treat-to-target strategy, and the mean time to pregnancy was around 85 days compared to the PARA cohort in whom they didn't receive the treat-to-target strategy, in whom the time to pregnancy was more than 200 days. This is the last study that I want to highlight. It is about the predictors of subfertility in patients with rheumatoid arthritis. 245 patients, they completed the study. And you can see that here that those with DAS28 less than 2.6, they have better chances to have successful pregnancy, and they have shorter time to pregnancy compared to those who have higher DAS28. And again, here you can see in the graph down, that those who didn't receive a steroid or they received prednisolone less than 7.5, they are also shorter time to pregnancy than those who received higher doses of steroid. So they have concluded that the time to pregnancy in RA is longer in older age group, and nulliparous have higher disease activity, use NSAID and steroid more than 7.5 milligram. So to conclude, as per the ACR guideline, we have to open the discussion with our RA female patients and child age group, and we have to discuss the pregnancy plan, and we have to apply the treat-to-target strategy to those patients using the sulfasalazine, hydroxychloroquine, or TNF inhibitor, because this strategy will shorten the time to pregnancy compared to those on other strategies. And over 50% of women achieved pregnancy within 90 days using the treat-to-target approach, nearing the general population rate. This is my last slide. Thank you very much.
Thank you very much, Dr. Somaili, for this concise, informative lecture. It's my pleasure to introduce our next speaker, Professor Mohammed Umair. Professor Mohammed Umair is also consultant of rheumatology at King Saud University, King Khalid University Hospital. He's also the founding president of Rheumatic Disease Association and Fibromyalgia Association charity. And he is going to talk about seronegative arthritis long-term view. Welcome, Dr. Professor Mohammed.
بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا محمد صحبه أجمعين. I would like to thank my dear colleagues in the scientific committee for inviting me to present this very important and interesting topic. Before I start, I just want to give you some metaphor on seronegative and seropositive RA. If you have two kids, same sex, almost close age, usually people outside the family compare them by their performance at school, or when they are employed, by their success at work, or if they are daughters, in addition to that, if they get married quickly, or they get more kids, happier in their life. And the problem that if you go from inside in the family, parents look at this in a more deeper way, that not one is better than the other, but each one of them is special, and each one of them has his own needs. And this is what, when you go to your clinic next week, this is the message that I want you to, or I would like you to consider taking it, that patients with seronegative RA and seropositive RA have different needs because of they have different diseases. Maybe after 10 or 15 years, seronegative RA and seropositive RA will be two distinctive diseases, and will have different recommendations, like the ANCA-associated vasculitis, like the other form of vasculitis, the spondyloarthritis. They all have been lumped initially and then segmented later on. With that, we can talk more about these two diseases, from genetics, pathogenesis, till the way we treat them. So, seropositive RA is basically diagnosed when a patient has inflammatory arthritis with either a positive rheumatoid factor or ACPA antibodies, and there are no other explanation. And seronegative RA is somehow considered in the field of rheumatology a diagnosis of exclusion, where someone has typical inflammatory arthritis in specific joints with a negative serology, and there is no other better explanation. Now, if we look at the genetics, the ACPA positive, and now ACPA positive patients are more homogeneous in their genetics compared to ACPA negative, even if they are rheumatoid factor positive. There are some distinctive differences between seropositive and seronegative RA patients. One of them is the famous shared epitope. So basically, what is the shared epitope? The shared epitope is a segment in the chromosome 6, which is important in antigen presentation, where there is more arginine that is then citrulinated, which will lead to antibodies and then antigen-presenting cells going into T cells activation and the autoreactive T cell development and the development of RA. So in patients who are seropositive or ACPA positive, the shared epitope alleles is more linked to the disease. So it can explain the development of RA more in ACPA positive, in 18%. So 1/5 of patients, you know what genetic driver is causing the disease. While in ACPA negative, it's only 2.4% because there are many other factors leading to the development of seronegative RA. And of course, if you have two alleles, you have higher antibodies, you have more aggressive disease, more erosion and disability. When we talk about the hormonal aspect, of course we know that one of the hypotheses why rheumatoid arthritis affect females more than males are because of the sex hormones. And in this large study, which is called the Nurse Health Initiative, so it's a mega study that had been done in the US. They looked at many diseases, including rheumatoid arthritis, one of them. They found that reduced estrogen in either menopause or premature menopause was associated with both, but more with seronegative RA. So a reduced estrogen will increase the risk of developing seronegative RA more than seropositive RA. And as you know, in most cohorts globally, rheumatoid arthritis affects patients between the age of 40 to 60. You see younger patients, you see older patients, but this is around the menopause in most of the patients. Again, this is another study which is called, this is like the GWAS, but this is a PHEWAS, so Phenotype-Wide Association Study. So they actually go to claim data or electronic data, and then they try to cluster patients according to a disease, to a subtype. And basically, this is what I want you to look at. So the first part of the column are the ICD codes for diseases that have been in patients with seronegative RA. And you see these are all like soft tissue injury, degenerative disc disease. Here, myalgia and myositis, you can see here a small note. These patients did not have myositis. When they manually reviewed these patients, they found that this is only muscle pain and aches, but no evidence of inflammation. Spinal stenosis, spondylosis, myalgia. While in patients with seropositive RA, they had more airway disease, more inflammatory problems compared to the seronegative RA. So if you take a huge group of seropositive, seronegative RA, and you look at their comorbidities, they are somehow different. This is a very beautiful study, and I don't think that we have a lot in the literature, and this is a cohort, a prospective cohort, that evaluated the development of fibromyalgia in RA patients. And this is an early cohort. It's not a long-standing or established RA cohort. And you could see over the years, at 3 years, about 10% of your patients will have fibromyalgia, regardless of their disease activity. What is interesting is that a CCP positive or seropositive patients had half of the risk of developing fibromyalgia in this group. So we now understand that seronegative RA patients are at a higher risk of developing fibromyalgia compared to seropositive. Now, over the years of the last maybe 2 decades, many autoantibodies tried to be in the care, the clinical care of RA patients, like the anti-carbonated protein, like the anti-ROSC2, and others. But all of these autoantibodies, despite that these publications are like 7, 8, 9 years old, none of them was really translated into clinical care. Now, still as rheumatologists, we have only the rheumatoid factor and CCP. Compared to the myositis panel that is expanding over the years, and the lupus panel where more autoantibodies are being evaluated, in RA, we're still, in status quo, we have rheumatoid factor and CCP. And this is the question that many patients and many colleagues from outside the rheumatology field ask: how many patients from seronegative convert to seropositive? And I'm going to show you a group of studies from different cohorts. So this is a UK cohort that looked at 640 patients who at baseline had CCP in 28%, rheumatoid factor in 29%, and 21%, both after 5 years in the CCP negative patients who had multiple testing for CCP. So most of these studies that I'm going to discuss were not prospective studies. They were retrospective, looking at people who had multiple CCP testings for any reason. Usually we don't do that in clinical practice, but these studies, they just looked at patients who had multiple testing. And they found that the seroconversion after 5 years is 2 and 4.6% for CCP and rheumatoid factor respectively. And similar results was seen in this cohort from the Netherlands of more than 500 patients, where they found that out of 44% of CCP negative patients, the one who had multiple measures, 2% seroconverted to CCP positive, and in 53% of rheumatoid factor negative patients, 3% converted. And this is a Japanese study where, again, they looked at a larger number of patients initially, and then they just segregated patients who are CCP negative, and they found that out of 149 patients who were negative, 5.4% seroconverted. One of the studies have shown that one risk factor for seroconversion from CCP negative to CCP positive is being rheumatoid factor positive, which is okay, but it does not really add any information or change in the practice. Now, do both have similar long-term outcome in disease control and disability? Now, obviously, maybe not. This is a study from the Netherlands. It was published in PLOS Medicine, which is a good journal. It's a Q2 journal, but it was really badly written. The table is very difficult to understand. Like, I spent a lot of time reading this study just to understand what message they want to deliver, and this is the message they want to deliver. So, in patients who are seropositive, they have a higher level of sustained drug-free remission, a higher mortality because of chronic inflammation and cardiovascular disease, and more functional disability due to joint destruction. And this is a Mexican study. Of course, in Mexico, they have low access to biologics, so these disabilities and erosions are not really seen in patients who have high access to biologics. You could see at baseline, seropositive patients had 11% erosions progressing to about 40% compared to almost none in the seronegative population. If we go to comorbidities, the most important طبعا are cardiovascular comorbidities. And this is a Spanish study comparing seropositive, seronegative. This is a small study, but they just did a very simple exercise. They calculated the cardiovascular risk in age and sex matched patients, and they found that there is no significant difference between the two groups. And this is the CATCH cohort, which is an early arthritis cohort, which again showed no significant difference in the development of cardiovascular disease in patients with rheumatoid arthritis over 5 years. And lastly, this is a large database study from different centers in the US, including Stanford, with 160,000 patients. And again, you see a trend toward seronegative RA having more cardiovascular disease, but no statistical significance. Now, do we treat seropositive and seronegative RA patients the same way? Of course not. We have some differences, and maybe I'll just highlight this part in the EULAR guideline. There are actually some changes in the new EULAR guideline that are going to be published. So you just need to ensure to read between the lines, between the two guidelines. Now, in this guideline, poor prognostic factor, the first one is, of course, being seropositivity, to go for a biologic once the patient failed methotrexate compared into attempting a second conventional DMARD if a patient has no or few poor prognostic factors. Now, in multiple clinical trials, the percentage of seropositive or the ratio of seropositive to seronegative has been always stable in most clinical trials. And this is, again, a quick list: anti-TNFs, IL-6 blockers, abatacept, rituximab, and even tufasnib. Now, it is important to remember that when you look at the newer JAK inhibitors or the JAK1 selective clinical trials for baricitinib and upadacitinib, you see a way higher percentage of patients who have autoantibodies. So in the baricitinib trial, you have 87, 88, and 89 in the three groups. While in the rheumatoid factor, you have 92, 90, 91, so almost no seronegative in this trial. In this, one of the possibilities which would explain maybe the small superiority that you see when they compared Bari and UPA to adalimumab. And again, you could see here, rheumatoid factor and or CCP positive, about 90% in the groups compared to the 60, 70% in the previous clinical trials. This is a systematic review that's shown that anti-TNFs work exactly in seropositive and seronegative, and one hypothesis might be that some patients with seronegative might have other diseases like psoriatic arthritis with no apparent skin disease, and it treats just the whole lump and whole group. Rituximab is the only drug that we have what we call a biomarker, where patients who are seropositive have a higher or have double the response of a seronegative. So rituximab in seronegative is only used in specific cases when patients have important comorbidities like interstitial lung disease or lymphoproliferative disorder or infectious disease like TB. While in tocilizumab, it has clearly shown better results in patients who are rheumatoid factor positive, not ACPA positive. And similarly in abatacept, it showed a higher response in rheumatoid factor positive. But in abatacept trials, it was mainly driven in patients who had very high autoantibodies, in hundreds and hundreds. This is a study looking at the response in patients who used tufasnib comparing seropositive, seronegative. They did, multiple combinations of autoantibodies, and they found that tufasnib might work better in seropositive, but only in the 10 milligram BID dosing, which is not the dose that we use. So basically, tufasnib acts similarly to other biologics. And there are no data in baricitinib or upadacitinib comparing seropositive and seronegative. This is the only study that I was able to find where they lumped all JAK inhibitors, but there was a good number of patients on the 3 JAKs, which showed basically no difference between the response in seropositive and seronegative RA patients using JAKs or even other biologics. So in conclusion, seropositive RA and seronegative RA are 2 different diseases or subtypes that have different needs. It's not that seropositive RA is more severe, more serious, and require more aggressive therapy. It's just that each one of them has its own needs, and we need, as rheumatologists, to adjust to give these patients the better care. I don't really like rheumatologists who just focus on inflammation, because you're not treating inflammation, you're treating patients. And despite that, we had a lot of understanding in RA pathogenesis. We do not have more autoantibodies that will help us diagnose patients. Seronegative RA patients, over time, they might have another diagnosis over time. So I have some of my seronegative RA patients, they eventually end up being CPD, psoriatic arthritis. So it's important to really have this kind of routine re-evaluation of seronegative RA patients and ensuring that you're treating them properly, especially when they do not have a well-controlled disease or achieve remission. And finally, there is no significant difference between biologics, so any patient can use any medication. You have shared decision, comorbidities, pregnancy planning. All of these factors play a role in the management of these patients. And finally, we will need more certification later on. Hopefully, we're going to come close to our colleagues in hematology oncology, where they have excellent certification for their patients in the management, in the diagnosis, and in long-term outcome. Thank you.
Thank you, Prof. Mohammed. Now we'll time for question and answer. Please, Dr. Ziad al-Zahrani and Dr. Mansour al-Sumaili, come to the stage. And we'll start, if anybody have any question to... Yes, Dr. Asawsan?
And large joint destruction.
Sorry, again?
An observation from seropositive. I have many cases with seronegative, unfortunately delayed diagnosis and till the time large joint destructions, more than even small joint damage.
So the question is delayed diagnosis?
Late diagnosis for rheumatoid arthritis, because patient they presented with large joint destruction rather than complaining of a small joint. Is there any different in seropositive, seronegative, and large joint destruction? Is it more in seronegative?
So there are many studies, and there is also a recent Nature communication paper showing that the patient journey to reaching a diagnosis of rheumatoid arthritis is longer, more complicated in seronegative patients compared to seropositive patients. Patient comes with inflammatory arthritis in the family medicine clinic, a rheumatoid factor and CCP are requested, one of them is positive, refer the patient to rheumatology. While in seronegative, they roam around for a longer period, they see more physicians. Now, destruction is a more of a feature of seropositive RA because of the more aggressive inflammation and the synovial hyperplasia that destroy the joint, more cytokines in their synovial fluid. While in patients with seronegative RA, because they might have an older age, they might have associated osteoarthritis, you might see maybe secondary osteoarthritis more accelerated in these patients because of the delayed diagnosis. But nobody would really see more destruction in seronegative RA compared to seropositive RA. So there must be another explanation.
Yes, Doctor.
Thank you for all professors regarding this amazing session. My question for Prof. Ziad. What about the changing the route of administration of methotrexate in controlling the disease activity? We have some patient doing well on oral, then they get less improvement. After changing the dose for subcut, may improve the condition. Any data regarding the changing the route of administration in controlling the disease activity before decision of stoppage of MTX for our patient?
Yeah, thanks. Very excellent questions. Certainly, the use of subcutaneous methotrexate is definitely superior in terms of the efficacy and probably less in terms of the side effects. There is actually, I think, the name Professor Carter Thorne from Canada in Toronto. He is more towards using the subcutaneous methotrexate even from the beginning of the disease. They start with high doses of methotrexate, and in his cohort, they call it the catch cohort, they found that those who use basically higher doses of methotrexate, in fact 25 milligrams right from the beginning, and then step down, he had actually good result in terms of the responses even without going into biologics combination. So certainly the methotrexate bioavailability is definitely better with the subcutaneous administration, and especially when you talk about doses exceeding 15 milligrams, because it's going to be erratic in terms of the bioavailability with the oral methotrexate. You will notice that some of the patient may have also this GI toxicity, more with the oral, and if you go to the subcutaneous, the patient may tolerate it better than using it orally. So certainly, I think we should use more subcutaneous methotrexate than mainly oral, because the efficacy is better, and you can go with higher doses of methotrexate than the oral.
Okay, my question for Prof. Sulaiman. In practice, what's our decision regarding female patient get pregnant on MTX?
Sorry, can you say it again, please?
In practice, what's our decision regarding female patient get pregnant during using MTX? Because we have this dilemma. We have many patients using methotrexate and get pregnant, and the pregnancy continue without problem. But what is the decision for us as a rheumatologist if we have female patient get pregnant during using methotrexate?
Yeah, you know that you have to stop methotrexate 3 months ahead before they will conceive. But the problem is not in discontinuation of methotrexate. The problem how to control RA from the time that you have stopped methotrexate till she will have successful conception. And this is the time may it will compromise the infertility, and also may it will also lead to more pregnancy morbidities. So you have to give an alternative. And as we mentioned, hydroxychloroquine, sulfasalazine, or 10-FI, which should be started before pregnancy and continue during pregnancy. But of course, methotrexate should be stopped.
I know, but if we have patient get pregnant during using methotrexate, what's our decision?
Actually, you have to discontinue the drug. You have to continue the folic acid. And you have to tell the patient that there is a risk of teratogenicity, and you will ask your obstetrician to deal with those patients. Basically, I have a few cases in whom they continued, they conceive while they are on methotrexate. Almost majority of them, they have been aborted. Abortion, yes, is very common in those who continued methotrexate. But of course, some of them, they will continue their pregnancy, and there is a risk of the teratogenicity.
Still, mashallah, the speakers, they give us 10 minutes, alhamdulillah. Thank you very much. Dr. Atiyah, you have a question?
Assalamu alaikum. Thank you all speaker for the excellent presentation. My question for Prof. Muhammad Umair regarding the NTCCB and correlation with disease activity. I saw some practice of some of our colleagues. They are giving the treatment of rituximab according to the NTCCB level. Although the patient in the clinical, he's clinically or she is clinical, in clinical remission. During your talk or your search, when you are preparing the presentation, have you ever saw any seroconversion of anti-CCB from positive to negative regarding with the treatment? What do you comment regarding this?
So if we go to the original clinical trials of rituximab, yes, they have seen a seroconversion from seropositive to seronegative. In some long-term observational cohorts, you might see a very small percentage, again, less than 2% of patients, regardless of the medication they use, whether anti-TNF, abatacept, tocilizumab, a seroconversion from seropositive to seronegative. But again, this is of no clinical use at the current time, so it is not recommended to repeat it. You should not look at the level, and the response might vary in these patients. So yes, there are patients who seroconvert from positive to negative, but a small minority, and usually these are the patients who have a low titer of CCP, not the ones that have 500 or 600 CCP level.
Dr. Prof. Bahlas.
شكرا. Thank you all speakers. سؤال للدكتور منصور. What's your answer للبيشنت يعني around 30 years old تيجي تقول لك what about freezing of my ovaries? Should I do freezing? Especially if you start high dose methotrexate.
Yeah, actually, I don't have an accurate answer for your question, but actually, the methotrexate it will not affect the fertility. Usually, even if they receive methotrexate for a long time with high doses, usually they will remain fertile. Once you stop the methotrexate, they can conceive. So there is no indication to freeze their actually ova. And for males, you don't need to freeze their sperms. There is no issue about the methotrexate and infertility. The only risk, as you know, is the teratogenicity.
Thank you.
Anyone have question? Yes, Doctor.
الصوت ما هو واضح.
I recall, till they give the question, I recall the obstetrician, the IVF, they was arguing with them. They are using adalimumab for inflammatory pelvic, it's increasing the chance of fertility in inflammatory pelvic disease and endometriosis. So that's interesting.
Yeah, actually it is successful, and it may also stimulate the ovulatory process.
They found that some patients with infertility, primary infertility, they found that they have very high TNF levels. And by blocking it and reducing the TNF level and altering the immune response, the rate of pregnancy increase. So you're going to always you have to be ready because an IVF specialist is going to call you to start adalimumab on a lady who's infertile.
So my question for Dr. Mohammed Umair. So nowadays we have a preclinical treatment or preclinical trial, the trial for preclinical treatment for RIA, like BIBRA study, treat early. I want to know what is your point of view about this type of study and their impact in futures.
This was the last week's talk in Cairo, actually. Now, preclinical RA, patients have features of RA, including positive autoantibodies, positive family history of rheumatoid arthritis in first degree relatives, who might have symptoms or do not have symptoms. So a patient might be asymptomatic, only autoantibodies positive, or might have some non-specific joint pain without clear evidence of synovitis, either by clinical exam or by imaging. The bottom line of this question is that it's a shared decision. You have to discuss with the patient whether yes or no you need to treat him at the current phase, with a lot of uncertainties, including for how long, what is your outcome, who's going to pay for the medication, and all of these aspects. Preclinical RA is still a new concept that we need to be cautious, and it's all about deciding whether to treat or not. So a 65-year-old lady who has multiple comorbidities, who developed this state, is not like a football player that takes 1 million riyal per week. Each one of them has his own needs, risk stratification, and a decision to take.
Thank you very much. I think, please nobody go from the hall. Please all come in front here. We'll take a photo. And after the photo, coffee break, inshallah, for 15 minutes. Please come to the stage. Thank you very much all.
السلام عليكم ورحمة الله وبركاته. حياكم الله في الفترة ما قبل الأخيرة في هذا الاجتماع المبارك. نشكر الدكتور محمد وعبد الله والآخرين على التنظيم الممتاز والاستضافة الجيدة، جزاهم الله خيرا. أول متحدث في هذه الفترة هو الدكتور محمد عطار، انتقل طبعا من مستشفى إلى مستشفى، وهو الآن استشاري روماتيزم وباطنة في مستشفى الملك سلمان الحرس الوطني في الطائف، وهو سيتحدث عن أنكا ستوري latest chapters. فليتفضل.
Assalamu alaikum wa rahmatullah. Good morning, everyone. It's my great pleasure to be here with you today, and I'm really glad to be here, and I would like to thank the organizing committee for having me here. So my talk for today is going to be about the Anka story. Probably this is something that we use all the time, but just to revise what happened in terms of discovery. So sometime in 1985, there was a patient, a white female patient, 16 years old, who was admitted because of an arthritis. She had severe pulmonary hemorrhage, she had glomerulonephritis, she had skin rashes. And then they admitted her and they started the testing. So the ANA was negative, the anti-GBM was negative, her complements were negative. And then they've done for her all sorts of biopsies. So they've done kidney biopsy, they've done lung biopsy, and skin biopsy. So the kidney did show evidence of necrotizing glomerulonephritis. The skin did show evidence of leukocytoclastic vasculitis. And the lung biopsy did show evidence of capillaritis, but there was no granulomas. So there is some sort of inflammation, but they didn't know what is it exactly. Now, their differential diagnosis, they thought of Henoch-Schlein-Purpura, but there was no IgA deposition, so for them that's not the case. They thought of Wegener granulomatosis, but there was no granulomas. Now, remind you back then that Wegener granulomatosis was described somewhere around 1930. So the diagnosis was there, but it was only that you have to find granulomas in the biopsy. With Baxter syndrome, she didn't have anti-GBM, and for lupus, she didn't have ANA. Now, they have some problems back in 1985. I think every century there is some problem. But back in 1985, they didn't have really a consensus diagnostic term or criteria. For that, the cause for her disease was unknown. The treatment or the appropriate treatment that she should receive was actually not agreed upon, and her prognosis was also unclear. So there was an encounter between her primary physician and a nephrologist, a pediatric nephrologist, in the hallway. So that took place actually in the University of North Carolina Hospital. And they were talking, and then they were saying, have you seen the new article that's linking the autoantibodies and Wegener granulomatosis? And they actually took the sample from the patient's sera, and they have incubated it, and they've sent it for the test, and the immunofluorescent was positive for her. So they actually went back to their patients at the University of North Carolina, and they brought any patient with crescentic glomerulonephritis, they brought patients who has Wegener granulomatosis or polyarthritis, and they've collected their samples, biopsies, and they've sent it for the ANCA testing. So 85% of their patients actually tested positive, and hence that leads to the publication that links the autoantibodies, which is the ANCA, with the two subtypes, and they started the clinical description of that. So if you look at it, it wasn't really so far away, and the transition from being at the bench to clinical science was really relatively quickly the way we are using it nowadays. So then the question that, does ANCA cause the disease? Is it the reason why we have vasculitis? So many clinical evidence did link ANCA, and it did show that it has a really pathognomonic effect on developing the disease. However, it's an association though, right? Because it really differs from what type of disease to another, like GPA is different from eGPA, for instance. And probably you've seen this before. If you look at the association between ANCA and specific ANCA-associated vasculitis, what really interests me is the last bar, the one that actually shows the negative ANCA. So you still can diagnose ANCA up to 20%, sorry, GPA, up to 20% with negative C ANCA. And that's go with MPA, and that's even go higher with eGPA. So it is associated, but it's not really pathognomonic. And then obviously we all know the other causes that actually can lead to positivity of ANCA without having the disease. So obviously there are some certain drugs that have been described in the past. The antithyroid medication has been described excessively. The use of hydralazine, allopurinol, phenytoin also has been described. And if you move away from medications and go to the other causes, like, for example, infections, this is a cohort for patients who have infective endocarditis, and you find probably 18% of them, they actually tested positive for ANCA. So that goes, but in less frequency with other infections like leprosy, aspergillus, TB, and other infections as well. Again, if you go and look for non-vasculitic diseases, you also find it present in multiple diseases like cystic fibrosis, inflammatory bowel disease like the ulcerative colitis or Crohn's disease. So it is important, but I think this goes, like for us rheumatologists, I think we find ease interpreting this autoantibodies. However, if you actually contact or communicate with someone from other specialty, they'll find it a little bit difficult, because they always thought that if you have ANCA, then you have the disease. So it is important to the degree that even in the latest ACR-ULR classification criteria, this is, by the way, it's for the GPA, they actually granted 5 points if you have ANCA testing positive. So it is important. It's not diagnostic, but it has high value in developing these diseases. And then obviously we know the type of diseases that arise from ANCA-associated vasculitis. It's a wide landscape. Small vessels are everywhere. So everything can be involved, moving from skin, kidneys, lungs, upper airway. But obviously, the percentage actually differs from the type or the phenotype of the disease itself. So if you want to go through the mechanism, the interaction between ANCA and the neutrophil, it's the initial reason and cause for activation of the alternative complement pathway that will result into influx of many pro-inflammatory cytokines. Eventually, this will end by scarring and damage. And it's really important, if you want to go therapeutic-wise, to actually try to align the treatment with the assumed mechanism. So if you use glucocorticoids, glucocorticoids does target the immune response. So it's not really specific for the process, but it does target the immune response. That goes also with the rituximab and cyclophosphamide. However, plasma exchange the aim for plasma exchange is actually you're going to remove the ANCAs. You're going to remove the inflammatory scene that has been done already. Avacopan, which is the latest new approved drug in this field, actually it works in a more specific way. So it actually targets the complement pathway, and probably, potentially, it will prevent the damage. So whenever I meet patients who has ANCA, there are a couple of questions, there are a few questions that comes to my mind. One of them is, what is the glucocorticoids regimen that I'm going to use? And what's the immune suppressant that I'm going to choose as well? So now, what we have to do with the plasma exchange nowadays? Should we do it? Should we not do it? And where is the place of Avacopan? I know it's available in some hospitals, in many hospitals they don't have it. So where does it actually come? Where is it actually beneficial? Sorry. And then how to maintain remission? Probably these 5 questions are the most important questions with any ANCA-associated vasculitis patient. And then I added this question because recently I came across one of these patients. So what should you do in specific or special situations? So to answer what glucocorticoid regimen, you go back to many recommendations we have nowadays. So if you go and look in the 3 recommendations, you will find the glucocorticoids is the cornerstone. So there is no wonder about that. However, the ACR, they're saying that you use pulses. EULAR, they've suggested that you use specific dosage. KDIGO also, KDIGO, which is the one for the nephrologist, also they've suggested the use of glucocorticoids. So when we start to talk about glucocorticoids in this age and time, we have to address the PIXIVAS study. So this is one of the largest trials that have been done in the ANCA-associated vasculitis that I would say have changed our practice regarding the glucocorticoids. So as you remember, or as you probably have gone through it, this is a trial that is comparing the efficacy of having plasma exchange versus not having plasma exchange. But what I'm interested in is that they actually have compared the reduced dose glucocorticoids versus the standard dose glucocorticoids. So what happens is that all patients at the beginning, they receive the pulses of steroid. And then if you look at this black line, the black line actually shows the standard dose, the one that we are used to use all the time, the slow tapering dose of steroid. And the other dotted line is the reduced dose. So there is a reduction by 60% of the cumulative dose of steroid. So there is a substantial reduction in the dose of steroid. And this is the table probably you've seen about the reduced dose of the glucocorticoid in the arm with the weight. So it depends really on the weight. So you don't really have to remember the whole scheme, but the most important thing is that they want you to reach to 10 milligram by the month 3 and about 5 milligram before the 5th month. So they are really ambitious in reducing the dose of glucocorticoids. So what was found is that both arms, the one who used the standard dose glucocorticoids and the one who used the reduced dose glucocorticoids, they were non-inferior. They were actually identical. So the non-inferiority hypothesis was confirmed here, meaning that if you use the reduced dose, it's actually going to work as if you're going to use the standard dose. Moreover, the infection. So I think this is a big plus for us. So the infection, which is the leading cause of death by the first year in these patients, has reduced by 30% in the reduced dose glucocorticoids. So the take from the PIXIVAS in this regard was that the reduced dose glucocorticoids did not cause more flare or more active disease. By the way, their primary endpoint was death or end-stage kidney disease. So the reduced dose did not elevate these outcomes. And then it reduces the dose of infection, the rate of infection. One point is that they actually, most of the patients, about 85% of these patients, they received cyclophosphamide. They did not receive rituximab. So the question was, is rituximab going to do the same? And then this what has happened in the LOVAS trial. So LOVAS trial, it's a trial that has been done in Japan. Now, the only difference in Japan is that most of their patients, they have MPO vasculitis, seemingly less severe vasculitis. But anyhow, they have used the rituximab, they've done the same thing, and they actually have used a more ambitious reduced dose of glucocorticoids. The result of this was almost the same like PIXIVAS. They were almost identical to each other. The infections were even lower. However, there is one point that the patients who remained on the glucocorticoid, the reduced dose arm, was less. There is a lot of dropout, but this we can leave to another talk. So what is the glucocorticoid regimen? If you look at the different recommendations, they all have adopted this new approach, which is we use less glucocorticoids. Now then, there is something that I think argues with our beliefs or with our things that we are used to is, do we pulse or do we not pulse? Remind you that if you have to go and look, you wouldn't really find clear evidence on that. It's something that we are used to use, but if you go, where does it come from? There is no clear evidence, the 1,000 milligram. There is no head-to-head trial with other doses. But it's something that we have seen our teacher do, and then we keep doing till now. Obviously, there is a theoretical risk that of increased infection if you use the highest dose, but again, we have to reserve it for patient who has the most severe patients. All I'm saying is that I'm still going to use it, but I'm not really sure if you have to change this approach or not. So which immunosuppressant? Now we're talking about induction. obviously you have to go rituximab cyclophosphamide. And then these two medications, you use it for patients who has severe disease, life-threatening, organ-threatening disease. They've suggested that you have to start by rituximab or cyclophosphamide. How about if you're dealing with patients who have not that much of a severe disease or not organ-threatening? Then you can start with rituximab, but you can use methotrexate or MMF in some situations. What actually makes you use cyclophosphamide in this day and age is that if you can't reach rituximab, or if the patient has very severe disease, very severe kidney disease, or refractory disease. Otherwise, I would say that almost always nowadays we are going to use the rituximab based on the efficacy and then the trial. So which regimen we are using? We're still having the original RAVE trial suggestion, which is the 375 milligram per square meter every week for 4 weeks of rituximab, or the dose that we are using nowadays, which is 1 gram at day 0 and 14. Cyclophosphamide, if you follow it, it has a clear kinetics on how you use it still nowadays. The last square there is actually the combo. You actually combine the rituximab and cyclophosphamide. This is something that's not done regularly, but in severe patients is something that can be done. So when should we consider the plasma exchange? So there are two main trials in this regard, the MIPEX trial. And the MIPEX trial, in summary, they've said that if you use it in a patient who has poor kidney function or patient who are on dialysis, by the first year, about 50% of these patients, they will be off dialysis. So it actually shows some improvement at the first year, but if in the long term, it didn't really show that much of an improvement. The PIXIVAS study did not really support that evidence, and even with whatever analysis you do in this trial, it doesn't really show that the plasma exchange would help in this regard. However, this is a meta-analysis that they have pulled a lot of studies, even going back to 1980s and 1990s. And in this trial, the result was the benefit, actually supporting the plasma exchange for those patients who has a glomerulonephritis, an active glomerulonephritis. And the fine details in this trial is that if you go, the higher the kidney function, the better the response. Meaning that if you have someone who has creatinine of 300 or more, if you do plasma exchange, you have to do about 26 plasma exchange for 26 patients to prevent one end-stage kidney disease. However, if the creatinine is 500, you have to do, for 6 patients, they use the plasma exchange to prevent one. So the higher the creatinine level, the higher, it means that more of inflammation, the plasma exchange would work better. So this translates in terms of recommendations into that the benefit is there for patients who has creatinine of 300 or more. For the pulmonary hemorrhage, though, the EULAR did not really support it that well. It says it should not be used as a routine practice, but it's something that you can do. Just a reminder that even in patients who have an overlap with anti-GPM, the plasma exchange here would make better sense. So where is the place of avacopan? So the avacopan, so obviously the neutrophil will get activated by ANCA. This will lead to production of certain cytokines and products that leads to activation of the alternative complement pathway, and then the release of the C5a, the complement 5a. Now the complement 5a, it's the chemoattractant. This is the key player that actually would go and loop back, causing more of inflammation. So it has its receptors on the neutrophils and on the endothelial cells. So what avacopan does is try to block the interaction between the C5a and its receptor. And if you were able to do that, theoretically you'll be able to stop the loop, and then the other thing, you try to prevent the damage that happens on the endothelial cells as it has its receptor. So in the ADVOCATE trial, what they've done, they've tried to compare the two regimens, those who has the steroid taper dose versus no steroid taper dose on avacopan. So this was a 52 weeks trial. And then what it showed is that if you use the avacopan, it works almost like if you're using the glucocorticoid. So it's non-inferior to it, so it does work. But the additional or the advantage of the avacopan is the less use of glucocorticoids. So patients on the trial on the avacopan arm, they use about 2.5 grams as a cumulative dose of steroid if you compare them with the other group. So again, less use of steroid, this thing has been approved in this trial regarding the avacopan people. Again, there was a signal that patients who has worsened creatinine, they tend to improve later on while they are on the avacopan. So these, like their GFR is actually improves by time. So it wasn't really mentioned in the ACR because the approval of the avacopan was later on, but based on the EULAR and KDIGO, so you can use it as a maintenance, obviously. It's not an induction treatment. So, and then it has to be used as a strategy to reduce glucocorticoids. So it's one of these medications that they've suggested that you can use to reduce glucocorticoids. The KDIGO have suggested that this medication will be better for those who has high kidney functions because it might help in improving the GFR. So this is what we have now for the avacopan, but I guess the more we use it or the more we have experience on it, we know more on its benefit. So how to maintain remission? Again, rituximab nowadays, it's the thing that we have, usually we go to if we want to feel confident about our patient, but again, other medications can be used. However, for the rituximab, the two suggested doses was the 500 milligram every 6 months for 18 months. And then there was another suggested from another trial, which is the 1,000 milligram infusion for 16 months. The EULAR have suggested that you should keep these patients in remission for at least 2 to 4 years. They haven't really suggested which treatment, but this is the time that they suggested that you use medication for remission. How longer duration, obviously, most of us will use or do based on the patients themselves. But in this meta-analysis, they have tried different doses of a different regimen of rituximab to try to find out which is the dose that is sufficient for these patients. And it turns out that if you use the rituximab 500 milligram every 6 months, seems to be doing just okay for 18 months. So the end result was that 500 milligram for 18 months. However, I'm sure in this room, many of you have used it beyond 18 months based on your patients. There are other factors that makes you consider the type of disease, the relapsing nature of the disease, and etc. So back to our ANCA story, because I think this is one of the areas that we always kind of confusing. Do we use the ANCA as something, as one of the measures or tools to pick up the relapse or to guide your treatment? So it's really important to keep in mind that persistent raise of ANCA does not mean relapse. I think this goes on with other autoantibodies as well. PR3 ANCA, though it has somewhat an association with an increased relapse, MPO, it doesn't really have that much. So all of the recommendations, they have suggested not to use routinely ANCA monitoring to judge on your disease alone. So again, they're suggesting that we do whatever we do at the beginning. So you have to examine the patient clinically, you have to do your analysis, you have to do your stuff. And maybe you can add it to that, but you cannot really use it and depend on it and change treatment just based on the level of ANCAs. So this is, I'm coming to my conclusion soon. So I actually had one of my patients who was young at the time of diagnosis of GPA. So he actually has cavitating lung lesions. He's gone through the induction, he's gone through the remission with rituximab, and he's been off medication completely. So we are talking about, I think, 4 years after his initial diagnosis, doing well, he's fine. So then he called me one day because he has a shortness of breath, like he reported it. So when he went to the hospital, they've done the CT, everything looks normal, but actually he has stridor. So the stridor was different. It's not the same original manifestations he had. So actually he turned to have subglottic stenosis. And then obviously subglottic stenosis is something that you can see in ANCA-associated vasculitis patient. And what happened is the narrowing of the airways below the vocal cord. This is the subglottic stenosis. And again, it has like many levels. So some people can just live okay with some symptoms, and it can be very severe and life-threatening. So obviously, this is one of the areas that whenever we face some such patient, we call our seniors, we call those who are trained in vasculitis. Do you guys have something? So the latest BSR trial, the latest British Society of Rheumatology, they have released just last June, they have released their recommendation. Now their recommendation is almost aligned with what I have said already, but actually they have included people from the otolaryngology specialty. And then what they've come, what they come with is this statement, which I found in some terms they are really helping. So they've suggested that both the subglottic stenosis or sinonasal disease, these manifestations does require experts. So my patient, actually, I sent it to our ENT. Our ENT, and our ENT department was a good department. So he told me that I'm not an expert in this one. I would not really try to approach this patient. So this is an important point. If you don't have it in your region, please have it arranged with someone else, because your ENT and other services has to be expert in this area. Then the second point, they have, and probably the second point, you might see it as philosophical, but I actually enjoyed it, which is the term of limited GPA. So in my patient, back in our nomenclature, I would say that this is a patient who has limited GPA. It's only the airways, huh? But actually, they're saying that try not to use limited GPA. You might use something different, like ENT localized GPA. Now, it does seem that a bit trivial, but I think it's important, because if you just use limited GPA, you would think you would underestimate the manifestation. So they've suggested not to use this term and to adopt the new term, just to keep it in your mind, the seriousness of these manifestations. So the fine cut here is that use systemic glucocorticoids and use local treatment, injections, and trying to dilatation of these patients. But again, with someone who's an expert. Okay, so in conclusion, so ANCA is important, and actually the story of ANCA is really fascinating. How in the modern rheumatology era, how we adopt this antibody in our practice, and how does it come so far. Glucocorticoids is essential in most of our patients. I think if you go through this conference and into all conclusion slides, you'll find someone talk about the glucocorticoids. We have to use less of glucocorticoids, but we have to be cautious on how less we have to use the glucocorticoids. The benefit-risk individualization for your patient is always important, and I'm sure that we always do it all the time. It's possible to use less cumulative dose of glucocorticoids, and I think this is the main lesson that we have in the last 10 years. In severe renal failure, the plasma exchange here may actually help. Rituximab is non-inferior to cyclophosphamide, and hence we are using it and considered in severe patients as well. The rule, the avacopan is important therapeutic modality to reduce steroid, but still it has to prove itself and gain our confidence. And then if you have an ENT localized disease, we have to use this term rather than use of limited ANCA-associated vasculitis, not to underestimate the manifestation itself. By this, I thank you. If you have any questions.
Thank you very much. Excellent presentation, Dr. Mohammed Attar. And now it's my great pleasure and honor to introduce one of our most favorite rheumatology teachers, Dr. Ahmed al-Sheikh. He's a well-known senior consultant in King Faisal Specialist Hospital and Research Center, and he will give us an interesting topic of IgG4 insight from the EULAR recently. تفضل دكتور أحمد.
السلام عليكم ورحمة الله وبركاته. First of all, I would like to thank Dr. Mohammed al-Sultan and Dr. Abdullah al-Fraj and the organizing committee for inviting me to this meeting. Today, I am going to speak about an interesting disease, which also we call it a disease with many faces, like systemic lupus erythematosus. We are going to speak about IgG4 disease. It is a chronic immune-mediated fibro-inflammatory disease affecting nearly any organs. It was first described in 2003. We don't know the prevalence. However, it is it is a disease of middle-aged and elderly. There is a striking male predominance, and males tend to have severe disease as compared to women, which is a little bit unlikely if we consider this disease as an autoimmune disease. Therefore, we like to call it an immune-mediated disease rather than an autoimmune disease. Males tend to have more features of retroperitoneal fibrosis and pancreatitis. On the other hand, women tend to have head and neck involvement with salivary lacrimal gland involvement. It is characterized by a relapsing and remitting course. Immunopathogenesis of IgG4 is interesting, and it is very important to discuss because we can get some mediators which can be targeted for therapy. Activated B cells present a variety of antigens to the CD4 T cell and probably CD8. And this results in proliferation of the T cells which secrete bit of, unfortunately this doesn't work, as the perforin and granuzyme, which causes tissue damage or apoptosis. In addition also, the T cells produces mediators like IL-1 beta and TGF beta and interferon gamma, which also contribute or promote or induce the fibrosis. Furthermore, the macrophages clear the damaged cells, and in addition also, it produces some mediators that contribute to the fibrosis. And there is a third one as well, which is coming from the activated B cell, which secrete the platelet-derived growth factor, which also contribute or activate the fibroblast and resulting in tissue fibrosis, presenting clinically as mass or organ enlargement, lymphoplasma, cytic infiltrate, and storiform fibrosis. We are not, I already mentioned this, so we will not go over it again. Yeah, what is that? We don't know the trigger of this disease. Some HLA association was linked to certain manifestations, specifically pancreatitis in East Asia, namely Japan and Korea. Some autoantigens also were proposed as a trigger for this illness. However, the most modifiable environmental risk factor was smoking, which was linked to retroperitoneal and aortic phenotype. Estrogen exposure may contribute to the IgG4 mastitis in women. Clinical presentation of IgG4, first of all, it is an indolent onset, slowly progressive. You don't really see an IG4 which is rapidly progressive, going to the ICU within days or weeks. You don't see something like that, like for example in ANCA-associated vasculitis. Most of the cases they present with mass-like enlargement, which may mimic malignancy. Also with a factive inflammatory lesions, and the symptoms depend on the organ involved. Most of the cases have multi-organ involvement. Constitutional symptoms, interestingly, are uncommon. Fever is rare. When you have a patient with fever, you should think of something else, infection or vasculitis. Weight loss, however, is common only in cases of pancreatitis. IgG4 may involve any organ in the body. However, these are probably the typical organs which are involved with IgG4, which include the lacrimal gland, salivary gland, the orbit, aorta, lung, pancreas, retroperitoneum, and kidney. And the symptoms depend on the organ which is involved. For example, when you look to the head and neck, personally, I have seen more cases with orbital pseudotumor referred to us from King Khalid Eye Specialist Hospital. Also, salivary gland disease. Glandular involvement can happen pituitary with pituitary dysfunction and other neurological symptoms and signs. The lung involvement or the chest involvement in general mostly detected by radiology, like pleural effusion, lymphadenopathy, fibrosing mediastinitis, and others as well. The most serious abdominal and pelvis involvement is autoimmune pancreatitis and cholangitis. And for, I don't know, I think for just because the improvement in the invasive endoscopy and gastroenterology. In fact, I have seen at least 3 cases this year of pancreatitis and cholangitis, which are probably the most serious complication of this disease. In addition, of course, to retroperitoneal fibrosis, which may manifest with hydronephrosis when it may do some pressure on the ureters. This is a case of submandibular salivary gland enlargement as well as parotid gland enlargement. Here you can see the pancreas, how swollen and enlarged. But with the treatment, you see the pancreas now is shrunken and it is fibrosed. And in most of these cases, at least 50%, they will develop diabetes, and also they will not be able to make digestive enzymes. So both the exocrine and the endocrine function of the pancreas will be affected. Here is the proptosis, which is one of the commonest manifestations that I see, and you can see the enlargement as shown by the arrow involving the ocular muscle. And here you see this patient is trying to look to the right with his right eye, but he cannot because of paralysis of the muscle. Now, this is the retroperitoneal fibrosis surrounding the aorta. There are 2 subtypes of IgG4. The first one is a proliferative and it is usually multi-organ, involving the glands, in particular, pancreas, bile duct, kidneys, lungs, and lymph node. It is characterized by high inflammatory markers, which are IgG4, IgG1, IgE, eosinophilia, hypocomplementemia, and it is usually treatment responsive. On the other hand, the fibrotic subtype, it can be either single or multi-organ. The major organs involved include the retroperitoneum, mesentery, mediastinum, pachymeninges, and thyroid. Here, unlike the proliferative subtypes, the inflammatory markers are normal and no hypocomplementemia. The eosinophils are usually normal. Treatment response is less when compared to the proliferative type. Interestingly, most of patients with IgG4, up to 60%, they have allergic symptoms, rhinitis, asthma, and we don't know why. We don't know what is the mechanism behind this. And they tend, of course, to have high IgE and high eosinophilia as well. Also, there is a malignancy association, which is really a problem if we consider that malignancy is a mimicker of IgG4 disease. But also, there is a high rate of prior and concurrent cancer. But there is no consistent cancer type, and the causality remain unproven. The diagnosis. You know, there is no single test to diagnose IgG4. There is nothing like, for example, ANCA or anti-double-stranded DNA or anti-CCB or etc. So basically, you require a combination of clinical presentation, serology, radiology, and histopathology. So typically, if you have an unexplained lesion, in particular involving the typical sites that I mentioned before, pancreas, lacrimal gland, retroperitoneum, you need to consider IgG4 disease. You know, now even the surgeon, patients with pancreatitis admitted usually under surgery, you will find they do IgG4 subclasses. They will look for IgG4. Of course, supportive test IgG4, definitely, in addition to imaging studies. However, biopsy is important, as we will see. So the diagnosis of IgG4 related disease require integrated assessment. Biopsy confirmation is required when feasible. Okay, what about the serum IgG4? Serum high IgG4 seen in approximately up to 70%. However, there is a 30% of the cases the IgG4 is normal. IgG4 also can be seen in cancer, in sclerosing cholangitis, healthy individual, and other diseases. The sensitivity is up to 90%. And other labs that I mentioned before, high IgE, eosinophilia, hypergammaglobulinemia, hypocomplementemia. High IgG4, IgN, eosinophilia, these are markers for higher relapse risk. طبعا other modalities, you need imaging to detect organ involvement, exclude malignancy, and guide biopsy. The proposed imaging include CT, MRI, PET scan. A tissue biopsy, of course, it is the gold standard, but sometimes why? Because it confirms the diagnosis and rule out other conditions that mimic IgG4 disease, specifically malignancy and infection. But sometimes biopsy is not feasible, either inaccessible site or the procedure itself is risky. You know, from our experience, like proptosis of the eye, although they are coming from an eye hospital, and most of the time their biopsies are read in our hospital, but very rare to find a conclusive biopsy. But the biopsy, why? Because first of all, it is small. Number two, they may not access or biopsy the inflamed or the affected part. But at least the biopsy will be helpful to rule out other conditions, in particular malignancy. Similarly, the cases now that we encounter recently with biliary tract and pancreas, the biopsy were not useful, unfortunately. They were tiny, non-specific changes. So in this case, probably you need to depend on clinical. Of course, there is another factor that I didn't mention, is to find a surgeon to do for you the biopsy. This is another also difficulty. So you might here concentrate on clinical diagnosis, i.e. typical imaging, elevated IgG4, no suspicion for cancer, and the response to steroid. So best practice, biopsy when safe, clinical diagnosis only if the pattern is unmistakable, and alternative excluded. This is the same. Okay, now the biopsy, what we are looking in the biopsy. First of all, you look for the storiform fibrosis as shown here using the hematoxylin staining. Also in the lower slide, you can see obliterative phlebitis. That's because the veins are collapsed under the effect of the fibrous tissues. Lymphoplasmacytic infiltrate also is seen and can take shape of follicles. Mild to moderate eosinophil infiltration. Lastly is the IgG4 positive plasma cells. Most of the plasma cells should be stained with the IgG4. However, IgG4 positive plasma cell is not specific for IgG4. It can be seen, for example, in ANCA-associated vasculitis. So these are the typical pathognomonic pathology in patients with IgG4. Therefore, in 2019, ACR EULAR proposed classification criteria. And these criteria proposed a three-step entry, then exclusion, and inclusion. So the entry criteria, any of the features that I mentioned, especially when it is involving the typical organs, the patient here can enter the classification criteria. Secondly, you need to rule out utilizing pathology, radiology, of course, clinical serology to rule out other differential diagnosis. Then step 3 is the inclusion criteria, which they utilize scoring system. So the inclusion criteria structures domains. In each domain, there are variable, and each variable is scored. So you need a score of 20 to classify that patient as IgG4 related disease with sensitivity of 88, specificity of up to 99%. Again, you all know as rheumatologists, this is meant not for diagnosis, but for classification of the patient. Of course, there are other classification, in particular the Japanese, which was modified recently. Yeah, this is, I think, is important slide because with the radiology and serology, you might be able to diagnose the patient without biopsy. In this study, 74 patients suspected to have IgG4, 51 classified using the criteria as IgG4 disease. When they went retrospectively, they found that almost 20 of 51 patients, imaging alone was sufficient for diagnosis. Also, radiology and serology also was sufficient to diagnose the patient without biopsy. So the conclusion here, radiology plus serology criteria can classify 80% of IgG4 disease non-invasively, most often with pancreas and biliary system involvement. The management of IgG4 basically require to control inflammation and induce remission, and then maintain the remission utilizing different modality of therapy. Then monitoring the disease for relapse, for new organ involvement, and for side effect of the medication. Management should factor the natural course of the IgG4 because occasional cases may go into spontaneous remission. As I mentioned, the disease is indolent. However, progressive organ involvement occur, and additional organ occur over time, and irreversible damage of the vital signs can occur if the disease is not well controlled. Now, let us go into the disease-specific clinical factors to guide your therapy. Number one, the subtype, whether it is inflammatory or fibrotic. We know inflammatory is more severe and usually responsive to therapy as compared to the fibrotic. Number two, whether it is single organ involvement or multi-system. Thirdly, the urgency. For example, if you are dealing with a patient who is having biliary structure, it's different from dealing a patient with only lymphadenopathy. Also, predictors of relapse are important to be aware of them. Multi-organ disease, prior flare, high IgG4, high IgA, and peripheral eosinophilia. So steroid, is the first line in IgG4. Usually a high dose, like 1 milligram per kg, and then gradual tapering. The response is high, 97%, but 24 to 54% they relapse after reduction of corticosteroid. It means that we need a maintenance therapy, like in any other immune-mediated diseases. So here it comes the rituximab. Rituximab have been used now almost for the past maybe 10 or 15 years based on, retrospective evidence, case reports, case series, which found that rituximab is effective. This is a systemic review. Part of the systemic review, they looked into the rituximab and its efficacy. And they found that rituximab is highly effective for relapse and remission maintenance. In addition, it reduces the IG4 and minimize relapses. It is also steroid sparing and reduce the need for long-term high-dose glucocorticoid. It is also effective in multi-organ involvement, including pancreas, salivary gland, and etc., with good safety profile. In fact, rituximab was also used without steroid, as a matter of fact, when there is any contraindication to rituximab. Rituximab is used like in rheumatoid, or what we call rheumatoid regimen. Then what about the steroid-sparing immune suppressants? Yeah, like azathioprine, mycophenolate mofetil, less commonly methotrexate, tacrolimus, leflunomide. Again, this is based on case series, case reports. However, they are replaced by the rituximab. Cyclophosphamide was used for severe refractory disease. However, its use, has been reduced with the biologic, namely rituximab. Probably mycophenolate and azathioprine might be a good option for pediatric. Prior using it in prior using the B-cell depleting therapy like rituximab. Also, maybe azathioprine is an alternative during pregnancy as well. And there is here, I find there is a study, Chinese study, 155 patients. They compare cyclophosphamide versus mycophenolate mofetil. So two groups. One group received cyclophosphamide IV, 0.8 gram, and the other group received mycophenolate mofetil. Both were responsive, 98% versus 96%. But the relapse rate was higher in the mycophenolate group. 14 or almost 15% relapsed within a year, as compared to 4% with cyclophosphamide. So cyclophosphamide lowered the relapse risk more effectively than the mycophenolate mofetil. Yeah, but it's not working now. Okay. Just give me 2 minutes because this is important. What's happening? Yeah, it's okay. Okay, here, if we go here, we will find a medication. It is inebilizumab, which is the first FDA approved for IgG4 disease. It has been shown It has been shown, just quickly. What is that? Yeah, okay now. Because we have to move fast here. Okay. It has been shown in ipilimumab to reduce the flares and increase the likelihood of flare-free. So after this study, the ipilimumab was FDA approved in the treatment of IgG4. Okay, there are two other medication. I will talk about them briefly. One of them is the obuxilumab, which is acting on the CD19 and the FCYR2B. This molecule doesn't reduce the number of CD19, but it downgrades the function. And there is, and basically here, the conclusion from this study, this is, first of all, this is an open label, single arm study. It showed that obuxilumab highly efficacy and acceptable safety, supporting further trial. The other one, it is a monoclonal antibody directed against the BTK. There is also an open or phase 2 open trial using rilazabrutinib, which has shown, which is an oral, by the way, medication, which has been shown to be effective as well as steroid sparing. There was a 70% flare-free at 1 year. So monitoring, we'll skip that, and we'll go to our conclusion. The disease is a slowly progressive tumor-like mass lesion. We looked into the typical organs involved in the IgG4 disease. The diagnosis is challenging, requiring histological confirmation. ACR ULAR classification require an entry, exclusion, and inclusion criteria. Individualized treatment based on disease pattern, natural history, as patient and disease-specific factors. Steroid still is the cornerstone for inducing disease remission. Advances in understanding the pathogenesis has promoted development of novel targeted agents that may provide steroid-sparing option in the future. Lifelong follow-up is essential, and thank you.
دكتور محمد. Any questions؟ نشكر المتحدثين البارعين ومحاضرتين شاملتين ما شاء الله. Questions؟
طيب يعطيكم العافية على المحاضرات الممتازة. Prof. Ahmed, my question regarding IgG4. Is there any role for antifibrotic treatment retroperitoneal fibrosis in IgG4?
For the time being, no, there is none. But I think that might be in the future. For now, the concentration mainly on the on what I show you, especially the obexelimab, the anti-BTK. These are the markers that, or the moderators that they are trying to pursue in controlled, randomized controlled studies, because there is an initial response for them.
Okay. If you allowed me, Mr. Chairperson, for how long will treat?
Sorry?
For how long you will treat those patients?
Patients
Yeah.
with rituximab, for example?
Yes.
We don't know really. We don't. Personally, we treated them for long time. We reduced the dose of rituximab, like, for example, once a year. I tried to stop the rituximab in certain patients with a close follow-up. In addition, it depends on which organ is involved. If you are dealing with these severe cases like biliary tract or pancreatitis, I think the treatment should be for life. Because if they have a recurrence, that will be a disaster. Because already with one attack, they will lose significant pancreatic function, both endocrine and exocrine.
دكتور عبد اللطيف. Just comment for Dr. Mohammed. إن شاء الله تلحق على الطيارة إلى الساعة 11. Second question is how awareness is the ophthalmologist and ENT about this disease of especially the ANCA vasculitis and also the IgG4, because there is frequent presentation with ophthalmic and submandibular lymphadenopathy, and especially if biopsy done without considering IgG4 in the histopathology, they may miss it, or they just exclude malignancy and that's it, and the patient will be missed.
Dr. Mohammed.
Thank you very much, Dr. Abdelatif. So I think your point is very important, and I think one of the most important points, obviously we do serve the same patients. However, we work in different places. So your colleagues in other specialty not necessarily are up to speed with you. So I think this is the collaboration that you have to do in your region based on your hospital. So for example, you have to have your meetings with your ENT, you have to have your meetings with your ophthalmology, talking about these unusual situations like the orbital pseudotumor, the subglottic stenosis. This is something that not everyone knows. So as you mentioned clearly, they have to be more aware of. In other hospitals, specialized hospitals, they do have the luxury of having people up to speed. So at least if you don't have the service, or if you don't have someone who's confident in dealing with these patients, transfer them, because this is the best you can do.
Dr. Badr.
سؤالي دكتور أحمد الله يديك العافية. دكتور أحمد, my question, how frequently you see IgG4 disease, and what is the most common presentation to in your practice and you will see?
You know, we have been seeing it, more frequently in the past few years. And the IgG4 disease is, we don't get, a new cases directly. Most of the cases, they are coming from ophthalmology, ENT, and gastroenterology recently. I think there is an awareness, more awareness now, and they are looking specifically for it. Any case, and I saw now, of pancreatitis, you see them doing IgG subclasses, looking for IgG4. So I think there has been an increased awareness. The urology, I forget to say, urologists as well, because of the retroperitoneal fibrosis, and they will come to them. I have several cases, maybe 5 or so, they came from urology because of hydronephrosis.
Dr. Muhammad, has avacobin been used on its own as an inductive therapy?
As far as my knowledge, not yet, but mainly as maintenance for the time being.
Is it feasible, theoretically?
I suppose yes. I don't see something objective for that, but and especially for those, it's another aid to reduce the steroid. But in terms of efficacy, I'm not sure. But maybe for those who has renal involvement with high renal function, I can see its use in the future. But probably we have to have more evidence.
Dr. Ahmed, may I suggest that the two subtypes are one type, but caught at later stages, like the fibrotic stage was an inflammatory stage, was a proliferative stage, but it's basically not come to the attention of the physician until later.
It become fibrotic.
Possible?
Yes, very possible.
Any other?
Because, in the 90s, I remember, we used to see these cases, but we didn't know what are they. I have seen retroperitoneal fibrosis. I think these cases were IgG4, but nobody knows what are they.
Any other question or
I have last
one
question.
from the female side and then Jer.
يعطيكم العافية على very excellent presentations, both of you. I'm wondering, or I'm a little bit curious, if we have a well-known name for ENT specialists in vasculitis, or any centers that we can refer our patient for. This is the first question. The second comment to you, Doctor, that about the avacopan that we used before I came back to Saudi Arabia and Sweden, and it was used for induction with the cortisone, and it was a very good effect for avacopan. That's why we are trying to have it in our hospitals.
No, my question was on its own. I know it's used with steroids. تفضل.
Sorry, just to make sure, for the first question, are you referring, is there any specific centers that we can refer to, or what was it exactly?
If there is any specific centers or well-known name in
Right.
ENT vasculitis experts.
Right. No. So obviously we have some of our colleagues works here and there. Obviously, King Faisal Specialist Hospital, they have a good they have good vasculitis physician and expertise with other specialty. But the ENT is something that you have to look along. Like for example, military hospital, they have probably in Riyadh, in Jeddah. So you have to actually to look by name. For once, I don't really know, but. I don't know like a center for that, but you have to have an ENT who is really comfortable with dealing with airway diseases. So yeah.
Yeah, if I can. If I can comment, we really have a problem, with the subglottic stenosis. Really, for example, King Faisal, we don't really have a good, because you need somebody to know and how to deal with airways. And what I understand over the years, this is not the good, case that they would like to see. And they told me, some of the ENT, we don't have somebody with experience in the airways. I think in King Khalid University Hospital, Dr. Ahmed Al-Ammar is one of the ENT patients who is ENT specialist consultants who deals with this. You really need somebody who is expert in this. Otherwise, the general ENT, I don't think can help you.
We had a few cases of this, basically tracheal stenosis, subglottic stenosis, dealt with the King Abdulaziz University Hospital, because this hospital is specialized in eye and ENT only. So they deal with it in collaboration with Dr. Sultan Mghairin, who established his vasculitis clinic in King Abdulaziz to be closer to the ENT and the ophthalmology. And he's currently in Sweden because he's doing collaborative studies with the Swedish guys in vasculitis, and they have a large collection of them. السلام عليكم جزاكم الله خير ومشكورين جميعا حضورا ومحاضرين.
Assalamu alaikum. Now for satellite symposium will be sponsored by GSK and presented by Dr. Nazar Bakh. He is consultant rheumatology, King Salman Hospital.
Thank you, Dr. Mohammed, for the nice introduction. Today I will speak about the herpes zoster of vaccination for the patient with autoimmune disease. And I would thank GSK to invite me to talk about this wonderful topic. I start about what is the clinical impact of the shingles in our patient, why it's important, what is the clinical profile for the shingles, and how can we implement this in our practice. We'll start about that the herpes zoster at the beginning. As we know, chickenpox, it will be infected in the childhood, and then it will be latent phase. It will be latent in the dorsal root of ganglion, then it will be activated as a zosters with a reduced immune system. And its manifestation by that the skin scars, and it will be induced by 90% of the adult patient more than 50 years old, they will have the disease. And it's the incidence, it's around 6 to 8 per 1,000 of the person, and it's around 1 million new cases in the United States and 1.7 million in the Europe and 1.5 million in the China. And it consists with the phases. It will start with the prodromal phase, then it will be go to the acute phase, and then it will be goes with subacute, then we'll end with post-herpetic neuralgia. Prodromal phase, it's from the 4 days to the 2 weeks, and then acute to 2 to 4 weeks. Then the subacute, it's up to the 3 months. Then after that, it will be developed post-herpetic neuralgia. And we can see that in the skin lesions, from the beginning at the end, it will be start with the physicals, then it will be basilar, then it will be crusted, then it will be scarred. Here we can see that the acute presentation and complication and recurrence. Acute presentation, most of us, we know that it's a vesicular rash and it's very painful. Then the complication is like post-herpetic neuralgia and the other manifestations. And the most important for us is recurrence is around 6 to 10% of the patient. And why it's important to prevent the shingles? Because as we know, the immune system, it's reduced, it's activated of the herpes zoster virus. And these we can see in immunocompromised patient and more than 50 years old. Especially with our population, we have the diabetic and other autoimmune disease. What about the risk factor? The risk factor is including the chronic respiratory condition, its malignancy, HIV, diabetes, and which is common in our population. And we use of steroid. For use of steroid alone, it can be 6 times increased risk of shingles infection, and autoimmune disease like SLE and particularly and RA, it's increased twice that the risk. Severity of the factor can be elevated risk of herpes zoster like family history of BSA and BSO, family history of herpes zoster in the family, autoimmune disease, diabetes alone, it can be increased like 40%, increasing that the risk, and chronic vascular disease and HIV malignancy. Here we can see that the higher incidence of immunocompromised patient with herpes zoster, especially we have that the SLE and rheumatoid. And we can see comparing to other like the solid organ and the bone marrow and cancer and inflammatory disease. Here we can see that we have 40% of the hematological malignancy, they can be developed with the BHN, and here that the disseminated zoster, it's around 19% in hematological malignancy and 8.5% in solid tumor of the patient. And mortality rate is consists around 5 to 50%. RA alone, it can be affect or increase the risk of infection because of the disease-related immune dysfunction and our treatment. And here the herpes zoster is the second most frequent infection population with RA. the severity is associated with the developmental of herpes zoster. And there's no significant difference in the severity between herpes zoster in RA versus non-RA subject. Here we can see that the increased incidence or burden of herpes zoster with the SLE comparing to the healthy population. It's alone, it can be increased the risk around twofold. And we can see with the age, it's increasing that, the incidence of herpes zoster between the age of the 50 to the 60 and 60 to the 70 and more than 70 years. What about our medication? We prescribe that the JAK inhibitor, interleukin 6, and we have anti-TNF. Most of them is like increasing that the fault, it's with the JAK inhibitors as it's published, or it's the common side effect is activation of the herpes zoster, and the other there's increase like one fault. And here 40% of the cases they're receiving the biological treatment, they have severe cases, and the biological is increased alone risk of the herpes zoster comparing to the non-biologic. What about the clinical profile of the Shingrix, about the safety and immunogenicity? We have all of these trials. It's studied in HIV and the stem cell transplantation and hematological malignancy, renal transplant, and solid tumor. And the end point of them, it's the the safety profile and immunogenicity. And we know as the dose timing, it's the single dose, then the second dose, it will be 2 to 4 months after the initial dose. And here we can see that the immunogenicity and efficacy for that the patient with the Shingrix vaccine and transplant population, it's around 70%. And here with the hematological malignancy, it's around 90% or 87.2. And what about the side effect or the safety for the vaccine? We have two side effects. It can be local reaction and it can be divided to the general reaction. That the local reaction, it's including that the pain and redness as swelling as any of the vaccine, and we can see increasing in the first 3 days. And we have the other manifestation like the fatigue and myalgia and headache and GI manifestation, shivering, fever, which is very low. And it's more common with the population, with the young people. Here we can see that the safety profile of the Shingrix and that with the other medication like tofacitinib, biologic and baricitinib and rituximab and Upada and abatacept, and it's the same. And here that the Shingrix is not cause any RA flare, it's not changing in DAS28 or HAQ-DI, and the rate of a change in the disease remission is neither in the group of the JAK and other biological demand. And here we can see that the immunogenicity of the herpes zoster with the JAK inhibitors and the others, it's around immunogenicity is around 90% in the cohort study. And we can see here that the autoantibody is increased, comparable in the both group, the biologic and non-biologic. How can we implement this in our practice? As we know, we have the first dose, then the second dose. It will be given from 1 to 2 months, and this is make that the immune response increase by more than 4-fold. And here we have that the guideline for that recommendation of give the Shingrix for the general population now in MOH of the Saudi MOH is recommended more than 50 years old. We can give it. For the healthy population and for the people that they have autoimmune disease, which is important in our field, and that the diabetic and hypertensive. What about the SSR? SSR, the Saudi Society of the Rheumatology, they recommend, and we can give the Shingrix for all the population, except for that the rituximab and for glucocorticoid. They recommend glucocorticoid to be less than 20 milligram per a day to be safe to give that the Shingrix vaccine. For the rituximab, they recommend you will give the dose of the Shingrix at the same time of the rituximab dose, and will delay the rituximab dose around 2 weeks of the timing of the dose. What about the storage? Storage, we'll put it in 2 to -8, and we have that the 2 vaccine, and it will 2 vial. One, the first one, and the other one will give it from 1 to 2 months, and it's given to the intramuscular injection. And this is the last slide for me. Thank you for listening.
Assalamu alaikum. It's my pleasure to participate in this conference, and thank you for the whole community, all the conference committees. It is my pleasure to introduce our next speaker, Dr. Nadia Mtairi. She is physiatrist and pain medicine consultant, director of Medical Rehabilitation Center at King Fahad Specialist Hospital in Buraida. So welcome, Dr. Nadia.
Assalamu alaikum. Good morning, everyone. It's a great honor to be here today. I would like to thank the organizing committee for this invitation. I will talk about today. I will talk about very common disease that could be easily missed or misdiagnosed in the clinic. So, understanding myofascial pain syndrome, key insight for rheumatologists. Okay, so our learning objectives will be definition of myofascial pain syndrome, clinical presentation, how to approach patient with myofascial pain syndrome, how to differentiate between myofascial pain syndrome and fibromyalgia, briefly summarize the evidence-based treatment option for myofascial pain syndrome. Myofascial pain syndrome is extremely common, painful disorder that is originating from muscle and surrounding fascia, myofascial system. Myofascial system can be a source of vague pain and functional limitation by creating symptoms, picture that are not always clear and easy to frame. Myofascial pain is common among patients with MSK pain, a problem, and characterized by myofascial trigger points, which is a hallmark of this disease. A patient usually present with localized pain in a restricted area or referred pain of various patterns. Myofascial pain can exist independently, so as a primary or secondary to MSK pain. Also can be divided into acute and chronic. A chronic one usually worse in prognosis. Early diagnosis and treatment of myofascial pain with comprehensive multimodal approach is optimal. The etiology could be a result of traumatic event, either direct trauma or microtrauma, constant microtrauma to the muscle, which increase the oxidative and metabolism and depletes the ATP, which increase the nociceptive sensation, which leading to muscle stiffness. Also, it could be a result of ergonomic factors like overuse activity or abnormal posture, structural or mechanical factors like spondylosis, scoliosis, arthritis, radiculopathy, leg length discrepancy. Also could be a result from systemic factors like hypothyroidism, vitamin D, vitamin B12 deficiency, also iron deficiency, psychological factors, stress and anxiety, autoimmune disease, also polymyalgia rheumatica, or using for drug like statin. Epidemiology, it's accounted for 30 to 85% of MSK pain can happen at any age, but most commonly from 27 to 50 years. The gender remains unclear. 85% of patients visiting a chronic pain clinic. So the myofascia responsible for 85% of back pain and 54.6% of chronic head and neck pain. Sedentary individuals are more prone to develop active trigger points than the active one. Most common site, neck, shoulder, back. high prevalence among people with arthritis, so women with rheumatoid arthritis experience nearly twice the rate in comparison to the healthy woman. Increase the incidence of myofascial, orofacial muscle in patients with Sjogren disease. Pathophysiology, the exact pathophysiology is not well understood yet, but one of the most accepted theory is energy crisis of muscle fiber. Repetitive or prolonged activity can cause overloading to the muscle fibers, abnormal increase of acetylcholine at the motor end blade, which leading to consistent muscle contraction, which lead in turn to muscle hypoxia and ischemia. Intracellular calcium pump are dysfunctional due to energy depletion. So when the intracellular calcium increase will induce sustained muscle contraction, which result in developmental of taut bands. Induce pain by enhancing local release of inflammatory factor like substance P, also pro-inflammatory cytokines. Histopathology, under microscope, the trigger point showed a contraction node, local contraction of muscle fiber and narrowing endomysium, space between the muscle fiber. Also can appear under microscope like non-uniformly distributed, so rounded in the middle and narrowing at the periphery, decreasing number of mitochondria and shortening of sarcomere and accumulation of the inflammatory cells. History and physical exam. Usually the patient report the pain as dull, aching, also poorly localized. The onset could be acute or insidious. Symptoms may occur after muscle injury or overuse activity, or developed without identifiable precipitating factor. Some literature showed the acute onset could be occur after that specific event or trauma. So if the patient represents the pain or reported the pain after moving quickly in awkward position. Also, while the chronic pain may be result from poor postures or overuse. Vary in intensity from mild to severe, local or regional muscle pain and referred pain in specific pattern. Also, the patient could report sensory disturbance such as numbness. May note also disturbed sleep. Person with cervical or periscapular myofascial may have difficulty finding the comfortable sleep position. The myofascial trigger points of each muscle have their own characteristic and local and referred pain. For example, myofascial infraspinatus muscle usually refer the pain to anterior deltoid, lateral aspect of the arm, and radial half of the hand. So mimic radiculopathy, you should take care or careful about that. Here an example of the common muscle that we have seen. Here, trapezius muscle. You can see the X pointed to the trigger point, so the pain could be radiated to the lateral aspect of the face, lateral aspect of the head, lateral aspect of the neck, also to the upper back. Here also the gluteus minimus muscle. It's very small muscle, but could radiate the pain to the huge area. So it could radiate the pain to the posterior aspect of the thigh and leg, also to the lateral aspect of the thigh and leg. We have seen patients refer to us as a case of sciatica, but when you're taking the history and examine the patient, the patient found to have myofascial pain syndrome. On examination, taut bands and trigger point are usually found in the affected muscle. The taut band is the contracted belly, which can be palpated. Trigger point is a hallmark and tender to pressure and movement. Also can be aggravated local and referred pain by compression. Also can cause hypersensitive spot. So in palpation, what's that meaning? That means when you palpate the trigger point, you will reduce the patient's symptoms. Trigger points could be active, found in symptomatic patients, or latent, found in patients without pain, painful only by palpation. Taut band may cause entrapment of nervous component of myofascial system. The good example for that, piriform syndrome, which can cause entrapment of sciatic nerve. Clinical symptoms and sign, medical condition based on the clinical diagnosis. Most criteria include trigger point, recognition of pain when palpating the trigger point, specific pain referral pattern, and local twitch response. Applying pressure and trigger point causes reproduction of patient's pain. Sensory disturbance, hyposthesia, hyperesthesia may be noted in the same area where pain referred, limited range of motion, or decrease the function related to the involved muscle. Here, the sternocleidomastoid muscle, you should apply pressure when you're palpating muscle to be able to reach the trigger point and reproduce the patient's symptoms. So, for example, in sternocleidomastoid, you should squeeze the muscle between your fingers, between your thumb and index to be able to reach the trigger points. Approaching patient with myofascial pain syndrome, body diagram or pain diagram, you can give your patient the body diagram and ask them to label or mark the pain area. After that, you can take a hint about the type of pain. Also, pain quality, you can use numeric pain scale, visual analog scale, pain characters. So the patient usually reported the pain as dull aching or burning in nature. Elevating and aggravating factors, the pain could aggravated by cold weather, stress, relieved by heat, massage, and rest. Precipitating factor also, associated symptoms, so the patient could reported numbness, weakness, stiffness, limited range of motion, and sleep disturbance. Look for any joint deformity or abnormality, range of motion, muscle exam, bulk, and palpation. Also, you should do neurological screening, tone, reflex, power sensory. The aim of that to be able to differentiate between myofascial pain and neurological cases. Okay, here the body diagram. So we will start with the picture on the right side. You see the patient there, label almost the body area. So here, fibromyalgia until proven otherwise. And because the patient unable to localize the pain area or where is the source of the pain. While here in the two pictures on the left side, the patient able to localize or label the pain area and the referred pain. Workup, no specific lab tests confirm the diagnosis, using of imaging to exclude other MSK disorder. So ultrasound can be used to exclude bursitis and tendinopathy, plain radiograph to exclude spondylosis, laboratory tests to rule out predisposing factors such as hypothyroidism, vitamin D deficiency, hypoglycemia, and plate noise, or increase AMG activity by using electromyography. To be honest, is rare. Raring use that. Here, a study showed the promising use of ultrasound in diagnosis of myofascial syndrome, pain syndrome. So they able to see the trigger points and how can they differentiate the trigger points from the surrounding area. Still more, also this is another study, and still more research is needed to be able to use ultrasound in diagnosis of myofascial pain syndrome. Okay, differential diagnosis, tendinopathy, tendinitis, arthritis, bursitis, nerve entrapment, radiculopathy, spondylotic or discogenic pain, TMJ disease, autoimmune disease. For example, patients who have suffered from medial elbow pain should be evaluated for possible medial epicondylitis or cubital tunnel syndrome before label it as myofascial pain syndrome. Also, chronic pelvic pain in women. For patients with chronic widespread trigger points, fibromyalgia should be considered. Chronic fatigue syndrome. Okay, how to differentiate between myofascial pain syndrome and fibromyalgia? It's a simple comparison, brief also. So in myofascial pain syndrome, localized muscle pain, while in fibromyalgia, widespread pain. What's the meaning of widespread pain? On both sides of the body, above and below the waist, and including axial spine. In the myofascial pain syndrome, trigger points cause radiated pain, while fibromyalgia tender points, not trigger points. In myofascial pain syndrome may occur due to repetitive activity or injury, while in fibromyalgia resulted from central sensitization. Pain can be, in myofascial pain could be short-lived or last more than 6 months, while in fibromyalgia, chronic and long-lasting. And myofascial may resolve by itself, while in fibromyalgia may require lifelong management. Also in fibromyalgia, the patient usually have associated symptoms like sleep disturbance, cognitive impairment, anxiety, depression, fatigue, and acute myofascial pain resolved by itself or simple treatment, while chronic needs long-term management. And fibromyalgia is difficult to cure and needs long-time treatment. Okay, management. Pain education is very important, so you should educate your patient about the nature of the disease and the prognosis. The goal of treatment, pain relief, correction of a precipitating factor, and improve the function. The aggravating factor should be identified and treated. Best managed by interprofessional team. Pain specialists should be involved early in the care. Non-pharmacological treatment, active and consistent physical activity and exercise is effective strategy in the treatment, improve the mood and pain. So you should advise or encourage your patient to do active exercise. Sometimes they will say it's painful or I cannot do the exercise. You should encourage them because it will be, I consider it as the most effective line of a treatment. Posture correction to prevent microtrauma and muscle injury, education of stretching, strengthening, aerobic and relaxation exercise, ergonomic modification, sleep hygiene, balance and anti-inflammatory diet, physical modalities. The aim of physical modalities to relieve the pain and the patient able to engage in active exercise like TENS, heat pad, shock wave, ultrasound, EMG biofeedback, and laser. Manual therapies such as massage, acupuncture, manipulation, dry needling, psychological aspects, especially in chronic cases, mindfulness, relaxation, yoga, and meditation for CBT and psychotherapy in severe and resistant cases. There is a study which compared the using physical modality alone and in addition to home exercise. So the study included 31 control patients who received 6 sessions of heat therapy and TENS, and 32 patients who received the same treatment in addition to the program of self-massage and exercise. The latter group showed greater improvements than the other patients. Okay, here, example of stretching exercise of the common muscle. So for trapezius muscle, you should encourage your patient to do the stretching exercise here for gluteus muscle and here for quadratus lumborum muscle. Pharmacological treatment, you can start with simple analgesic and go gradually for strong painkiller. So you can start with paracetamol, non-steroidal anti-inflammatory drug, oral or topical, like naproxen, Voltaren gel, muscle relaxant like cyclobenzaprine, relaxone, tizanidine, antidepressant medication, tricyclic antidepressant like amitriptyline, and serotonin norepinephrine reuptake inhibitor like diloxetine. This one is for chronic cases and the presence of the mood and sleep disturbance. Start taking such drugs from low dose and gradually increase it to avoid the side effects. Several studies supported the use of amitriptyline in treatment of myofascial pain. Anticonvulsant like pregabalin, gabapentin, usually I go for this option if the patient could not tolerate the side effect of antidepressant or there is a contraindication to use antidepressant. Topical like lidocaine patch, opioids, there are no studies to support the use of opioid in the treatment of myofascial pain. Intervention, trigger points injection with local anesthetic agent, lidocaine or bupivacaine. Mechanism of action, inhibit aberrant and aberrant nerve signals within the region of trigger points, reducing pain, disrupting the spinal facilitation mechanism, maintaining the trigger points. Botulinum toxin that can provide long-standing relief for resistant cases. Mechanism of action, blocking acetylcholine release at the neuromuscular junction of the dysfunctional motor end plates, so inhibit muscle contraction. Nerve block, there is a conflict about the nerve block in the management of myofascial pain. In general, the complication of local injection is rare. Depend on the area, may include local pain, bleeding, bruising, infection, neural vascular injury, and penetration of underlying organ. Especially, you should be careful when you inject the trapezius to avoid the pneumothorax. As an example, for lidocaine side effect, anaphylaxis, CNS depression, arrhythmia. Here, study compare the The aim of the study was to compare the effectiveness of trigger point injection using botulinum toxin and bupivacaine, both in combination with home-based rehabilitation program. There was no significant difference between the botulinum toxin and 0.5% bupivacaine group in duration or magnitude of pain. Considering the high cost of botulinum toxin, bupivacaine is deemed more cost-effective injection for myofascial pain. As I mentioned early, the botulinum toxin for resistant cases. Another study, the patients in the study were separated into a group of 20, one of which was treated for 4 days with lidocaine patch applied to the area of trigger points. The second group received the placebo patch, and the third group was treated with injection of 0.5% bupivacaine. The group with lidocaine patch and bupivacaine injection group found significant decrease and increase irrespectively in subject symptoms and pain threshold. Although the effect at muscle trigger points and target area were more pronounced in the injected group, there was no improvement in placebo group. Prognosis: acute myofascial usually resolves spontaneously or after simple treatment and elimination of aggravating factor, and chronic one lasts much longer. Complication, if not treated well, may cause reduction of quality of life and function, can transform to nociplastic pain or fibromyalgia if not treated. Long-term pain associated with mood disorder, so can cause anxiety and depression. Okay, this is my reference. Thank you.
Thank you, Dr. Nadia, for this brilliant presentation with nourished information. It is time to welcoming Dr. Ous Abu Abad. He is a consultant rheumatology, associate professor, and a consultant rheumatology in King Saud University. Welcome, Doctor.
Assalamu alaikum jami'an. So I'd like to first thank the organizers for their invite. This is actually my first time in this conference, and inshallah, ليس الأخير بإذن الله. So I must admit, when the organizers asked me to present about chondritis, I thought I had many ideas on how I'm going to present this talk, but I ultimately decided to sort of take you on a historical journey of chondritis and its relation to rheumatic and systemic autoimmune diseases. So in 1923, a German physician by the name of Wartenhorst described the first patient with this condition who presented with recurrent chondritis of the auricles of the ear and nasal septum with systemic features. And he called this polychondropathy at the beginning. So that was the first ever case documented about patients who presents with recurrent chondritis and inflammation. And in the literature, we don't really see anything for about 40 years after this case report, up until 1960, where Carl Pearson, who's a physician at the Massachusetts General Hospital, described a cohort of patients who had recurrent chondritis. He had 12 patients, and what's new about his case series is that he expanded the spectrum of disease. So he also described patients not just having recurrent inflammation of the ears and nasal septum, but he described patients also having peripheral arthritis, as well as airway involvement with laryngeal involvement and tracheal involvement. He also described patients also as having recurrent ocular inflammation, as well as middle and inner ear involvement leading to hearing loss. He also was the first to describe damage of this disease. So on biopsy, they found that the cartilage was replaced by a fibrous connective tissue after recurrent inflammation. And he also was the first to describe or use the term that we currently use of relapsing polychondritis. So this term started being used in 1960. About 15 years later, the first prospective cohort by Lawrence McAdam was published, and he described prospectively a study of 23 patients and reviewed the literature of other patients with similar presentations. And this cohort was the first to describe the patient's characteristics. So they described that this disease has an equal sex distribution between males and females. And also they were the first to describe 30% of these patients having an associated systemic autoimmune rheumatic disease or an autoimmune disease in general. So patients had Sjogren's syndrome, systemic lupus erythematosus, Raynaud's phenomena, as well as other autoimmune diseases such as autoimmune thyroid disease or inflammatory bowel disease. Mind you, in the 1970s, most of our classification criteria that we use for our diseases have not been published yet. So these were just based on physicians' diagnoses. McAdam was also the first to propose the first diagnostic criteria that we currently use in the diagnosis of this disease. So he proposed 6 criterion: bilateral auricular chondritis of the ear, non-erosive inflammatory arthritis, nasal chondritis, ocular inflammation, respiratory tract involvement or airway disease, and lastly, audiovestibular damage from inner and middle ear involvement. You had to have 3 out of 6 of these clinical criteria to be classified or to fit the diagnosis criteria, and ideally with histology or biopsy. However, this was not necessary, but preferably available. And then we really don't see any much advancement in this disease up until the 1980s, when radiologists started to first describe airway involvement, because airway involvement or airway assessment of this disease is very difficult clinically by history and physical examination. So the radiologists started to first describe this disease in the 1980s on CT tomography or computed tomography, and in 1983 it was the first paper that described involvement of the airway by CT scan. About 7 years later, radiologists also found that static CTs may not be enough to detect airway abnormalities in this disease, and expiratory phase CTs can catch malacia and airway collapse if it was suspected. So if you look at this picture, for example, on the upper side, you can see that the airway is patent when the patient in an expiratory phase, or when an image taken in an expiratory phase, you can see the airway collapse. So it's something to think about when to order CTs for patients with relapsing polychondritis and the airway involvement is suspected. So the clinical takeaway from that time, around that time in the 80s, that airway involvement in relapsing polychondritis is evident, and it has to be suspected early. And CT scan is the first line diagnostic, is the first diagnostic imaging modality if airway involvement is suspected. And lastly, and I know this discussion has taken place earlier about airway management in ANCA vasculitis, but to bring ENT, and I also would propose interventional pulmonology as well. This is a new subset or specialty of pulmonology that is, I believe now there are new graduates of this subspecialty in Saudi Arabia, so they can also help in managing airway in these patients. In the early 2000s, this was the era in rheumatology where large longitudinal prospective cohorts of our rare diseases started to be published, and predominantly in lupus and other diseases, but relapsing polychondritis was no different. The 2 largest cohorts that were created around that time one was in the US and the second one was a French cohort, started to publish the results of large numbers of patients. And then this is a rare disease, so large number of patients cohorts essentially equals 142 patients. However, these cohorts were really helpful because they found that relapsing polychondritis is essentially clusters into 3 different buckets. The first bucket is airway predominant disease. So these are patients with predominantly airway disease. The second bucket are patients with ENT and ocular predominant disease. And the third bucket are patients who have recurrent chondritis, but without significant systemic symptoms. So constitutional symptoms, fever, and high inflammatory markers. When we talk about airway disease, another mimicker of this is GPA, right? It's because GPA can cause airway involvement, subglottic stenosis. So it's a very important differential. Obviously, if no other clinical symptoms of vasculitis exist to help us determine the cause. But also in relapsing polychondritis, some of the subsets of patients can have vasculitic symptoms as well. So in this comparative analysis, they concluded patients with airway involvement in relapsing polychondritis and GPA, and they found distinctive features on imaging that could help us distinguish the two. So GPA typically favors a subglottic stenosis in a small segment of the airway. So if you look at this image, you can see this is a patient with GPA with subglottic stenosis. Whereas relapsing polychondritis favors a diffuse cartilaginous airway. So it affects essentially the entire airway because of the cartilages around the trachea. IgG4-related disease is also another mimicker, and I'm happy that I followed the ANCA talk and the IgG4-related disease talk. Some rare cases of IgG4-related disease can affect the airway, and they may show a similar pattern on CT. These are images from bronchoscopy of a patient with IgG4-related disease. However, when these lesions are biopsied, it will show the classic storiform fibrosis that we see in IgG4-related disease. And fortunately, patients with IgG4-related disease, when they have airway involvement, they typically have the classic head and neck involvement with lacrimal gland involvement. So it's helpful to distinguish IgG4-related disease from relapsing polychondritis. So I'm going to skip over the clinical takeaway. I'm going to now talk about the targeted therapies and advances in therapies in the era of the 2000s and 2020s. Classically, relapsing polychondritis was treated or is treated with glucocorticoids and the classic conventional synthetic DMARDs, such as methotrexate, leflunomide, and sometimes azathioprine. However, this is essentially based on expert opinion and very small observational data. No randomized controlled trials exist in relapsing polychondritis. However, evidence in advanced biologics started to emerge in the early 2010 and above. And this is essentially the largest systematic review that looked at essentially practices of physicians in the management of this disease. And they polled around 177 publications, and the overall conclusion of the systemic review is that the best overall outcomes were observed in TNF inhibition, as well as tocilizumab and abatacept, as well as methotrexate. However, the question now becomes, is one of these three buckets of phenotypes in this disease tend to respond more with one class over the other? And the answer is yes. So in this systematic review, looking at airway predominant relapsing polychondritis, TNF inhibition was associated with a superior outcome. So these are the patients where you may consider TNF inhibitors as one of the therapeutic options after steroids. Tocilizumab has also had some evidence, especially in systemic or the patients with predominant systemic disease, where they have significant elevated inflammatory markers and constitutional symptoms. These patients, tocilizumab can also be used when TNF inhibitors do not work. Abatacept has also some evidence, but it's very low quality evidence, limited data. And rituximab had some controversial evidence where some studies showed its efficacy and others did not. So we're awaiting probably higher quality evidence to determine its efficacy. Now, I remember in November 2020 in the American College of Rheumatology meeting, they presented, Marcela Farada and her colleagues presented patients with UB1 mutation causing a syndrome that now we call Bex's syndrome. So that was the first ever report of that syndrome in 2020, I believe 2020. And she went on and looked at one of the cohorts of relapsing polychondritis patients who she follows as well, because she is essentially the owner of the cohort of patients in the US. And she tested them all for the UBA1 mutation of Bex's syndrome. And what she found is that 8% of relapsing polychondritis patients tested positive for the genetic mutation. And what they found are that these patients had very high active disease, resistant to therapy, and had higher mortality. And they found a triad of manifestations that would prompt testing for VEXAS syndrome in those patients, which is the male sex, having macrocytosis of an MCV more than 100, and thrombocytopenia of a platelet count less than 200. This triad, if it's applied in patients with relapsing polychondritis, carries a sensitivity of 100% and specificity of a 96%. However, this triad was created within that cohort itself, so it needs to be generalized on a larger population. Now, these patients with VEXAS-like, with relapsing polychondritis-like syndrome, having positive or testing positive for VEXAS, they do not typically respond to our traditional immunosuppressive agents. They're known to require very high doses of steroids. TNF inhibition, rituximab, tocilizumab typically fail on those patients. So this is a letter to the editor that was published in 2023. We're waiting on their final data, looking at ruxolitinib, which is a selective JAK1, JAK2 inhibitor, looking at its efficacy in VEXAS syndrome patients who have a relapsing polychondritis features. And if you look at it, this diagram essentially red and pink color means patients responded to the treatment, and green means that they did not respond. Purple means that they withdrew from the trial or from the study. The upper portion here looks at patients who, looks at the clinical features of patients, so clinical signs and symptoms. And the bottom looks at biological features, or biochemical features, like the inflammatory markers, cytopenias, and MCV. And if you compare ruxolitinib to other JAK inhibitors, they looked at baricitinib, tofacitinib, and abaracitinib. You can see that patients on the ruxolitinib side responded much better compared to other JAK inhibitors. However, the sample size is quite small, and they did not publish their full data, so we're awaiting their full data yet. But this is a promising agent to be used in this group or subpopulation of relapsing polychondritis patients. And with that, I believe I conclude. So I've taken you over the historical story of relapsing polychondritis since the 1920s, advances in imaging, recognizing airway involvement mimickers of relapsing polychondritis compared to other mimickers like PPA, as well as the subgroup population of VEXAS syndrome and their potential response to therapy. With that,
thank you for Dr. Aus. Dr. Nadia, could you come please to the stage if we have question? So there is any question or not? تفضل دكتور.
السلام عليكم. عندي سؤال للدكتورة نادية وسؤال للدكتورة أوس. الدكتورة نادية، طبعا قضية هذا الوايد بين سيندروم، أنت تقولين عندكم المايوفاشال بين سيندروم والفايبروميالجيا. العيادة اللي أنت فيها كم نسبة هذولي إلى هذولي؟ وبعدين أنت المحاضرة حقتك قالت NCTD، فهاو common are these NCTD و non-CTD؟
طبعا المايوفاشيال تقريبا approximately in each clinic you will see 3 to 4 cases myofascial. Myofascial pain syndrome in each clinic I see around 3 to 4 cases every clinic. Fibromyalgia common also but less than the myofascial pain.
هي قضية because you are specialized in
pain medicine.
CTD يعني؟
No, I'm specialized in pain medicine, so I see all the cases related to rheumatological disease or no. So in general, but most of the patients, the fibromyalgia patient usually, يعني most of them they have rheumatological disease, but not all of them.
But this is not reflective of the general pain in the community? Because we see a lot of fibromyalgia.
Yes, a lot of, yeah, I understand. A lot of cases, or a lot, I mean, in every clinic, I see my facial pain and fibromyalgia, to be honest. But the high percentage for my facial pain.
And the success rate in management between fibromyalgia and...
My facial pain will be improved. Fibromyalgia, you will stuck with the case forever.
سؤالي الثاني الدكتور عوسل. You said biologicals are used in relapsing polychondritis. Is that after steroids, with steroids, or without steroids?
So all of the studies looked at combination with steroids and attempt to taper steroids while on the biologics. So essentially they're started together and then steroids are tapered to see if the patients will at least be on low dose or no steroids at all. So they're not used in monotherapy.
Next question.
Yes, I have two questions, one for Dr. Nadia and one for Dr. Aus. Regarding a fibromyalgia patient, what is the criteria to in the treatment? Because some cases is severe, and some cases it can be reduced with exercise and some educations. So which case we need to make it to go for a psychiatry evaluation? Because I face some cases we need to refer to psychiatry, but not all majority of the cases.
Okay, to treat fibromyalgia, you should focus on three aspects at the same time: physical, pharmacological, and psychological part. You cannot focus on one aspect and neglect the other aspect. So if you want to reach optimal treatment, you should focus on three aspects. Psychological treatment, not refer the patient to psychiatrist, no, to psychologist. If you have in your hospital any psychologist who specialized in pain cases, you can refer the patient either need or not, because he will help the patient to give them strategies how to overcome or how to live with pain without affecting daily activity.
And regarding the treatment, for your experience with amitriptyline versus duloxetine, is there a difference?
Both of them will give a benefit or will help the patient. Usually I use combined medication, not one medication. So even I didn't reach the maximum dose, usually I add amitriptyline to help with the sleep and duloxetine to help with the pain. Because amitriptyline, you will start with low dose and the patient usually not notice any pain decrease with this small dose. So you can start as a combination treatment between duloxetine and amitriptyline unless there is contraindication. If there is any contraindication to use of these medications, you can add gabapentin. So I prefer combined medication rather than start with one medication.
Thank you. Dr. Aus, thank you so much for a nice presentation. Just I want to ask for the treatment of polychondritis. Is there a difference between if it is come with Fixer syndrome and it's more severe than the other cases?
Yes, the short answer is yes. It carries also a high mortality compared to the non-Vixus relapsing polychondritis subtype, and it is typically resistant to the conventional treatment, to biologics, and they essentially require very high doses of steroids based on the case series that were presented in I believe ACR 2021. So that's why other mechanisms of actions are being explored. So for example, this JAK inhibitor, ruxolitinib, is used by hematology for the most part. It's a JAK inhibitor to treat myelofibrosis and polycythemia rubra vera. But they are using this mechanism to see if it will help in this specific mutation to halt the inflammatory pathway in that specific subpopulation, because now we think it's a different disease. Relapsing polychondritis with Vixus is thought to be a different disease than the classic relapsing polychondritis, because if you look at the VEXAS syndrome in general, you'll see a lot of patients meeting classification criteria for other rheumatological diseases. There are some patients who meet classification criteria for small vessel vasculitis. Some other VEXAS patients meet classification criteria for GCA, so not just relapsing polychondritis as well.
So, any further question, Doctor?
Thank you to both speakers. My questions to Dr. Nadia. How can we differentiate between the myofascial pain of the gluteus muscle and the trochanteric bursitis? This is the first question. And the second question is, you mentioned about injecting the trigger points with lidocaine. Is there any role for injecting the trigger points with steroids?
Okay, so trochanteric bursitis on the lateral aspect of the thigh, the pain. Gluteus muscle, the pain usually on the posterior aspect of thigh and leg. Sometimes it radiated the pain to the lateral aspect. The point here, by palpation. Once you touch the gluteus muscle, the patient will jump from the pain. So you reach the trigger points. Trochanteric bursitis, the pain with internal, external rotation of the hip, and usually there is a sign of inflammation and the patient, and you cannot even touch the area of trochanteric bursitis. While in myofascial pain of gluteus muscle, no, you can, but by palpation, deep palpation, you will reduce the patient's symptoms. This is the first question. Second question, sorry, can you repeat again?
You mentioned about using lidocaine to inject the trigger points. But is there any role to inject steroid?
To be honest, nobody recommend steroid, but from my own experience, I leave it as a last option. When I tried lidocaine multiple times and the next visit I add botulinum toxin and no improvement, that time I mixed the lidocaine with the steroid injection and inject the patient, but with small dose.
Any further question? By the end, I will thanks all our colleagues in Al Qasim region and all our senior consultant and prof, and see you inshallah after 1 year. Thank you.
الله يعطيكم العافية جميعا ونشكر الجميع على حضورهم وتفاعلهم ونراكم إن شاء الله في المؤتمر السادس السنة القادمة. الغداء في الدور التاسع والمصلى في القبو. حياكم الله.